people who are leaders.
Who's the greater the effect? So eventually, no matter what your tolerance, you reach respiratory depression, coma, and death. Buprenorphine gives a strong opioid effect, but at a medium level,
A young man who
a lot of other avenues that we see some people
and who have tried.
This is a new day. This is a new day. Show up and share to the people in the school that are back. We are the lifeguards of tomorrow. We are creating the future by predicting the future.
That the only way you can predict the future is to make it happen.
This is the vision that each one of us can help save ourselves, our family, our friends, our clients, and our patients.
Is to deal with our fellow human beings on this earth with compassion and a recognition that there by the grace of God go I.
Hi, I'm attorney Angelo. I used to be a teacher, football coach, assistant principal in a high school, prosecuting attorney, and now defense attorney. I've been doing this for several years, have experience in several counties, several states, and even 2 different countries. The reason why that's relevant and important because it identifies the 3 major thrusts that I have in various hats that we're wearing in substance abuse. Our first one is www.Summit's Coalition Registry, and that is our Substance Abuse Coalition Summits Incorporated nonprofit corporation designed to foster, maintain, and create a learned debate in substance abuse without any emphasis on any particular style, any particular profession, and it's information and educational only. The second effort in our substance abuse effort is www.preventdrugandalcoholrelapse.com, Signature Hill Independent Substance Abuse Professional Network. Throughout these travels, we have come across like-minded professionals in education, law, and medicine, and we work together and teach together. And that organization, that independent association of like-minded professionals, is identified under this website. And our last effort, our third in substance abuse, is www.legaldetox.com, patient defendant applications. Throughout these travels, we have found all too often patients and defendants who need help for them and their families. And when that happens, the area of actually providing professional services directly to the client can be found in that third and final emphasis. Leading now toward that first nonprofit Summits Coalition effort, it's very important for you to understand some very important facts. 8.5% of Americans over age 12, that's 25 million people, are identified with a substance abuse problem. That's more than lung, breast, and prostate cancer combined. More recent estimates unofficially are as high as 40 million people. Only 1 in 7 admit that they have a problem. Only 1 in 4 get any type of random treatment. Although our 40-year trend of arresting 1.6 million abusers annually may be dropping, not in the 16 to 28-year-old bracket. Although the United States is only 5% of the world's population, we have 25% of the world's prison population. Overdose deaths are second only to vehicular deaths in the United States. Our 40-year war on drugs has cost over $1 trillion, and its biggest failure appears to be being used to justify a new legalizing mantra. Although those facts sound very dismal and very discouraging, the coalition is working on a way to turn those facts around and to create a priceless opportunity to unite the educational, legal, and medical community, and thereby the entire community, in a historic effort that is going to show real progress. This unification process is multidimensional. First, by uniting lawyers with doctors, we see three major advantages. The most abundant source of properly motivated patients comes from the legal community. The legal community provides the opportunity to make legally binding, long-term, recovery-centered, extended care. And lastly, providing the legal community the best individually prescribed local health-centered treatment plan is a byproduct of connecting lawyers and doctors. By uniting medical providers and treatment providers to each other, we facilitate the coming together of all the latest care options. Coordinated counseling, in and outpatient strategies, medicine-assisted pharmacology tools such as monthly non-addicting injection, Suboxone, pain med management, and methadone. By uniting educators, we not only unite all three of the community's major professions, education, legal, and medical, we also take full advantage of local brick-and-mortar community teaching centers and their professional staff. Proactively reach as many new citizens as possible and reactively provide the best and latest professional informational help. Professional educators teach legal and medical professionals the most efficient cooperation techniques. Provide a public forum for creation and maintenance of the most learned, ongoing debate. Medical professionals teach other providers latest applications. Legal professionals will teach other lawyers a cogent treatment argument where there is no diversionary drug court, or in an alcohol case, or where the court, for whatever reason, will not admit a particular defendant to the diversionary court. To seek out and properly work with local medical providers to provide treatment options and address health and legal issues at the same time. To use other legal areas like employment, domestic, custody, professional and school discipline law, all to include local health center treatment. We emphasize the phrase learned debate to prevent tidbit, soundbite, junk food knowledge transmission. Although a human being could sustain life by stopping at the local gas station and getting cheese crackers in a cellophane wrap over and over again, they probably won't nourish as in the way that you should be nourished by a balanced meal. Much the same way, tidbit knowledge blunts the appetite, makes the person feel like he's full, but does not provide the depth of knowledge in this very important, comprehensive, socio-economic government problem. Tidbit knowledge is not what we're into. We are looking for a learned debate. We're old enough and experienced enough to say sadly that we see too much rancor in debate that is centered or motivated more with the speaker trying to impress the listener with himself rather than impress upon the listener the need for proper help and care. Although the internet is a wonderful source of instant information, all too often it is waterboarding us with information that is much too voluminous, much too superficial, and strangling our ability to really grasp a subject. Our learned debate is designed to stop that and begin and maintain a learned debate over a long period of time. Most people aren't even aware of what they don't know. Sadly, although this is not a good thing, it can become deadly in this area of domestic problem. Lastly, it's all about freedom. Making the addict free, making him an ally. One of the scenarios we use during our training classes is to talk about the difference in World War II when the United States became an ally and how it changed, and it was a game changer in history. Now that we have assisted medication and these potentials, we now can incorporate, maybe for the first time, really incorporate the addict and alcoholic in his own defense. And having that key ally is very important because the addict and alcoholic with medicine-assisted treatment that is properly administered shows great promise in allowing the addict to be free to join the fight and to separate him from the compulsions of craving long enough to add a real team atmosphere. There's a story about Harry Houdini that's been told to me several times. Apparently, early in his career, he was struggling frantically to get out of some type of confinement. And he struggled and was almost to the point of exhaustion when he sat down and leaned against the cage and the door fell open. What Harry didn't know was that he was already free. The door was already open. He just failed to stop long enough and think his way through and try the door. This is all about a learned debate. A very gifted politician who was a former senator, former vice president, and former president of the United States, apparently famous for putting people together and getting things done, had a phrase on his wall that was framed. And the phrase said, "Come now, let us reason together." Maybe we're a lot freer than we think. It's very important for us to slow down, get good information, come together, educators, lawyers, medical providers, and everybody else in the community. Come now, let us reason together. Hi, my name is Attorney Angelo, and I have a very generous and prestigious group of lectures in our presentation for today. Our two-day drug summit takes place at Kennedy Catholic annually, and this year's event is in the future from this filming, and someday it'll definitely be in the past. But each year our goal is to come back to that high school and produce this drug event, this coming together of discussions. And our goal is also to go to other communities and produce similar discussions. And what we have tried to do is we've tried to pull the community together in the form of the major components: the law, the medical community, and the educators. They seem to be a natural fit. You know, traditionally the schoolhouse has always been your local community center, so geographically and logistically, with all the facilities they have, it provides a great place to begin a discussion. And the discussion also takes place in the school where we can proactively, hopefully, reach as many children as possible, and reactively reach those that we may have missed on drug and alcohol issues. We have found novel ways to teach, and Dr. Iacino will explain that in our Another Voice project. And Dr. Neil Capretta is here, and he sits directly in front of the camera. Dr. Iacino is directly to his right from Kennedy Catholic High School. Bill McLaughlin sits to the right of Dr. Capretta, and Nessa Smith sits to the left of Dr. Iacino, and David Sproat to the left of Nessa, and I am again Angelo Pepa. We are trying to give you an intellectual flavor to what we're doing, and by doing that, in this forum, outside of the two-day drug summit, you can take something home that it's a pulling together. And I notice in the back of our room that Dr. Barber just came up, and Dr. Barber, you would not, this is our filming composing, and here, you, Doctor, you can come on up and sit right here to your right, and Dr. Barber will be introduced. If you can go that way, you'll be fine. We're very informal today, and I am going to be the conversation bully, okay? Why? Because I got these guys to film. I have the right. More importantly, we will edit that out, of course. More importantly, it's important for us to get to the point. So these fine professionals have volunteered to follow those strictures, and we're going to go that way. Now, a couple statistics to give you a flavor for why this is important. Right now, auto accidents are the first leading cause of death in this country. Second to that is drug overdose. And we have some exciting news from Dr. Capretta on some issues on drug overdose. People are advertising their homes, and realtors have signs and people are going into those homes, and people are going to the bathroom and finding out what prescribed medication is in the medicine cabinets. Children are finding out what prescribed medication is at home, and they're having parties. There are more people in this country over age 12 that have a substance abuse problem than those that have lung, breast, and prostate cancer combined. Early studies, and these studies are as old as probably 2011 now, indicate as many as between 25 and 40 million Americans, which would qualify as an epidemic. Only 1 in 7 people appear to be seeking help. Only 40% of those people, or 1/4 of those people, actually get help. 1 in 4. We have another situation where the law, you might wonder, why is a lawyer standing up here in this issue? Well, I just got done explaining to you it's a community issue. But in addition to that, the law seems to be a good place to be involved too. We arrest 1.6 million people each year in this country for substance abuse and alcohol-related issues. We have 5% of the world's population. 5% of the people who inhabit the globe live within the borders of the United States. 25% of the prison population of the world lives in the United States. Okay? So doctors, teachers, counselors, I believe, it is my opinion, that the law provides a meaningful associate in this community effort, because if we think about it, the law has more motivated patients than we may find elsewhere. Secondly, and we'll get to this in a minute, the law may provide an opportunity for us to, once tested and once assessed, make a prescribed extended care plan binding. So those two opportunities are very important to me as a lawyer. And for you lawyers out there, what I'm explaining too is that Attorney Matt Mangino will be here later, and he will talk to you about sentencing. Those of you who appear in court should obviously try to defend your client so that he doesn't get sentenced. But at some point in time, if you don't win, you need to be thinking about sentencing. And how to sentence, what does sentencing have to do with it? Well, what happens to the patient? If you cannot improve his legal standing 1 iota, you still should be concerned about the health problem, because he or she will eventually get out of prison. So if you can do both at the same time, that's a good thing. So I am calling on attorneys to recognize maybe a higher ethical calling than you ever imagined, in that you connect somebody with meaningful treatment so that they find a way home eventually and save their life and save somebody else. Now, along the way, you may be able to help in sentencing too. We have issues going on in sentencing. For example, you will find some counties that have a diversionary drug court, and you need to make an argument to get your client into that court. Other counties have a diversionary drug court that you need to make an argument to put him into the court because he may not be qualified. Some counties have no diversionary drug court, and you need to be making a treatment argument. Other counties may be having a separate handling of DUI cases, and shame on all of us, and shame on you as an attorney, because attorneys have one thing that they can do. They can keep on talking, as I'm showing you right now, and they can't be interrupted. And when you have the floor, you make sure you do not let the court lump DUIs in a different bin as drug cases, because they are both substance abuse. All of that said, I'm going to direct all of our comments forward and ask you guys some serious questions, okay? Dr. Capretta, I will go to you first, okay? Dr. Capretta, could you please, for the camera, please tell us your name and everything again, and your background, and a little bit of your history and your licensing, etc.
My name is Dr. Neil Capretto. I'm an addiction psychiatrist. I'm the medical director at Gateway Rehabilitation Center, where I've been there on a full-time basis for 25 years. I started in the field of addiction treatment at St. Francis Hospital in Pittsburgh over 32 years ago. I'm certified in adult psychiatry with added qualifications in addiction psychiatry, addiction medicine. I'm a fellow of the American Society of Addiction Medicine. I'm on the board of directors for the Pennsylvania Society of Addiction Medicine, and I'm on numerous local boards for drug task force and overdose prevention.
Great. And Dr. Capretta, I am an attorney. I'm not a doctor, okay? But I need some help on a superficial manner here. We know that when we go to court, we only have seconds to talk. We have impatient judges sometimes, and sometimes we have a live courtroom and we have a lot of things to go through. So our goal for today is to cover everything in a superficial manner. So my understanding is that in addiction issues and substance issues, there are basically some major categories. We have methadone is a prescribed and a legal treatment. It is a treatment that's still being used. We have Suboxone, and we have now some people using, and the general term is medicine-assisted treatment. Is that, am I murdering that?
Correct.
Okay.
Correct.
In the world of medicine-assisted treatment, I used to call it pharmacology. We also have antabuse and alcohol issues. That's an older one where you get ill if you drink. And we also have talk therapy. Some people have talk therapy with no medical assistance. Other people have talk therapy with. And then one of the other tools that we have is naltrexone, which could be by tablet. We could have naltrexone as an implant. We could have naltrexone in a time-released injection called Vivitrol. And then we also have somewhere in there pain management, because I believe, and we'll talk about this a little bit later, the legal addiction problem. In the world of substance abuse issues, have I identified the major players?
Right. Those are some of the major players. I mean, addiction, as I've been trained and try to teach my patients, is a biopsychosocial spiritual disease. It involves all those components, and good treatment should individually evaluate each patient for their needs in those dimensions. And one size does not fit all. I think it's important that we look at each patient. Some may benefit from medicine, some may not. Pretty much everybody will need some type of counseling and therapy, but it's like staging cancer. I mean, some people may need chemotherapy, surgery, radiation. Some may need only one. Some may need just to be monitored and followed. With addiction treatment, too much of it now is fragmented. One place does a little bit of this, a little bit of that. Good treatment combines all of it together and what's best for the patient, and then you need to keep following up with that patient over time to adjust that treatment. And the good thing is the legal system can be a wonderful opportunity to help a person. Sometimes the best day in a person's life who has addiction is the day they get arrested and involved with the legal system, because that's an opportunity now to kind of raise their motivation to get them help, which can, end up saving their life and be better for the whole community.
I quickly go into my memory banks, and I've been doing this working with fine doctors like you for 13 years. I started with Robert Woolhandler, and we've trailed around the state and whatnot, worked with Bill and Nessa here literally on a daily basis sometimes. But I remember hearing a jurist named Judge Michael Barrace out east. And he was one of the first person who started using alcohol monitoring braces. And I remember his quote like it was yesterday. An alcoholic or an addict does not wake up some morning and decide that today is the day I'm just going to quit being an alcoholic or an addict. The legal problem can form a wonderful opportunity, not just a happenstance of something bad.
Absolutely. And actually research has showed that people who are forced or required to enter treatment because of legal reasons do just as well or even better than people who go on their own because they're required to continue going. What correlates best with success with treatment is sticking with it, continuing with it, and the duration of time. I mean, this addiction and drug problems are chronic diseases. It's not like just getting a shot of penicillin, and it goes away. People who do best are monitored over long periods of time. I've worked for years with the Pennsylvania State Physicians Health Program that closely monitors and treats their physicians over a 5-year period. But at the end of 5 years, their success rates hover around 85 to 90%. That's incredible. If we could provide that type of, even a modest form of that to the average person, we'd be getting much better results. And the legal system offers us that opportunity.
So if we take that properly motivated person, and by the way, studies support what you're saying, 37% of those people who do receive treatment are coming from the legal community.
Correct.
Currently, and those are those older statistics I was talking about. They change almost like the national debt figures do, but absolutely. So the attorney should have some working knowledge of, in my mind, now I'm now back in my area, and I'm saying that one of the things we teach attorneys is to know the things that you're talking about so that can be brought to the court's attention, because The courtroom is a long way from your office, I'm sure. And so if that can be put into a generalized prescriptive extended care plan and made an order of court or incorporated into an order of court, that would play right into what you're talking about, not only getting them in treatment, but keeping them in treatment and having them comply. And at the same time, that treatment, from what I just got from what you just said, may vary. In other words, treatment varies from person to person, but it also may vary within that person from day to day or month to month. Those tools may change on an ongoing basis. Am I correct or am I wrong?
You're absolutely correct. And as you said before, to speak to the attorneys, if you have a client who has a legal problem because of problems stemming from them having the health condition of drug addiction, think beyond just getting them off of this legal charge. Look at that as an opportunity. If you just get them off the charge and don't address the underlying problem, they're likely to have future charges, but more importantly, they're likely to progress and have more tragic consequences in their life. They could end up dead. So really see that as an opportunity to provide a humanistic service.
And one of the things we have our teachers teaching in CLE classes is that it's a higher calling. We all know, criminal defense lawyers, what a preliminary hearing is, a bill of particulars, a pretrial omnibus motion, a discovery request, trial by jury, unanimous verdict. There are thousands of volumes of books written on trial tactics and various things that you're supposed to give your client your best. But if we're talking about the client being a total person, a health-related person, as well as a legal-related problem, it's important to know that when they come out of that courtroom either winning in a jury victory or out of prison someday or out of a local jail, they do need to be in touch with people who can help them with that sometimes bigger issue.
Right. And it's a good idea for a humanistic standpoint, but even if you don't care about human beings, which hopefully we all do, it's a good investment financially. It saves costs. It saves costs in terms of the legal system, incarceration. It's been shown for every dollar you put into helping somebody with a drug or alcohol problem, you can reduce other medical and legal costs from $7 to $14. I mean, it's a good investment for our whole society, and it reduces crime. So, I mean, it's a win-win scenario.
Great. And Doctor, because you just keep taking me from one issue to the next, and we're going to get to our other speakers here in a second, I do want to pick up on that last one. It's been estimated that it costs $20 million a day in every state in the union for incarcerating substance abusers. And so certainly there is a financial impact to that also. And then we have the other issue on all of those, and Brian Welsh is somewhere in our audience, he's one of our staff. He talks about the cascading of all the other bad outcomes, separating a father from their family and a mother from the family. In Pennsylvania, once upon a time, 94% of all incarcerated females were there because of substance abuse related issues. So all of those children had no mother for all of that time. So I am going to pick up and come back to that financial issue, if I may, and I would like to go to Dr. Barber now. We have some exciting things on the horizon, and what we like to do in our Substance Abuse Summit here is always bring today and tomorrow to the plate. And Dr. Barber, we're going to take a cut here in 1 second, and we'll move our microphone and we'll go there. Tell our audience, just like you would be talking to the record, your name, please, and your background and education so they could become somewhat familiar with your expertise.
My name is Dr. James Barber. I am a board-certified plastic surgeon. I went to medical school in Washington, D.C., did training at Cedars-Sinai Medical Center in Beverly Hills, California, the Texas Medical Center in Houston, MD Anderson Hospital, and did a fellowship at Rancho Los Amigos Hospital in the University of Southern California. I'm a Newcastle guy. Came back here because I'm a huge Pitt fan. Had to come back and watch my Panthers play. So I'm back here in the Pittsburgh area for the last 29 years. I have been involved in a number of things since then. I have been involved in the congressional committees that have studied medicine, et cetera. I have done a number of things in that regard, a number of things involving medicine. Had the opportunity to write a book called The Forever Factor. My mom unfortunately passed away at 58 years old, and became interested in the genetics of how we live, how we do things, and studied that intensively, and came across things that we're talking about today that have piqued my interest, both in the use of genetics in the formation of personalized medicine, We're now going to take medicine beyond what it was before. It used to be one size fits all, trial and error medicine. We're now looking at the patient individually and training and looking at him and treating him for what he is, not as the mass. A lot of the things that Dr. Capretta said, I couldn't agree with more. It's a combination of things we think, psychotropic type of medications you're taking, pain medications. As you know, there's twice as many people a year who die in this country from opioid overdoses than from heroin and cocaine combined. So,
and now what we're told, we seem to have uncovered a new addicting medication. And we'll get to that with Dr. Capretta in a minute here. But it was very important for you to mention that Pitt background and where you're from in this community, because that's precisely why you and I are here. We're also community people. We see a problem and we want to pitch in and we want to give our 2 cents worth if it can provide some help. And so Dr. Barber, being a plastic surgeon, is recognized as a leader in his field, is now rolling up his sleeves in the community, and he's involved in some exciting new things that may play a role in our substance abuse issues. So can we go directly to the pain medication issue, for example? There's people who discuss the fact that legal addicts are becoming as big, if not a bigger problem, than illegal addicts, and that is people who are abusing pain medication. And so we think that you're involved in something that could provide some help there, so I'm not going to talk anymore and let you discuss that.
What Neil talked about and what you talked about, tomorrow is today. We're now looking at a different form of medicine. Now we could literally look at a patient and say, okay, how are you going to process this medication? Everybody handles medications differently. We have genetics that play different roles. We have what we call poor metabolizers. Poor metabolizers means you only get 28% of the efficacy of a medication that's supposed to be taken. We have an intermediate metabolizer. They get 72% of that medication. So if you're looking at somebody, whether it be an opioid, a pain medication, a psychotropic drug, you can test that patient based upon what he is and say, okay, you only get 28% of that medication. What that patient ends up doing is taking 2 or 3 or 4 Vicodin to get the same result as somebody would get getting the full effect of it. What ends up happening, they become physically addicted. There are studies now that have shown basically patients with codeine. There are actually black box warnings on a lot of these medications, over 200 medications now, citing genes that can affect the way you handle metabolism and how you affect medications. Codeine, for instance, they had a story where a lady gave birth at 13 days, and they cite the gene. She was what we call an ultra-rapid metabolizer. She broke down the medication so quickly that when she breastfed the baby at 13 days, the baby died. The baby was a normal metabolizer. She gave the baby such a hit of medication so quickly that the baby got 40 times the lethal dose and died. So they actually have warnings on the black box warning talking about it now. So wouldn't it be nice to know before we put a patient on a medication how they're going to handle that medication, how it's going to affect them? We now do a complete study. There's studies out there now that show complete. What you talked about with methadone, they now can test for methadone. They can test for all these type of medications to say, hey, this is the right one, this is the wrong one. Watching TV the other day, we just had a guy come back from Afghanistan. He's been on 16 antipsychotropic medications. They're not working for him. And what you need to do is be able to look at that patient and say, hey, it's not working for you because you're in the wrong class of medications. This is what should work for you. There are other tests available now in personalized medicine, for instance, patients on psychotropic drugs, where you can do urine tests and follow the level of SSRIs and GABA and dopamine to see if they're responding to the medications you do. Numbers out there are tremendous. You talked about saving money. Patients who have overdoses, for instance, patients who are admitted to hospitals. They cost the hospitals in 1997 an average of $5.6 million. That's probably $10 million today. Adverse effects in patients taking medications now are off the scale. It's the 4th leading cause of death in the United States. And they do this because patients are becoming addicted. They become addicted and they quit their medications, or they don't take them because they don't work anymore, because they don't metabolize correctly. So wouldn't it be nice to look at that patient before he's on a medication and say, this is the one you should be on. We can decrease the adverse effects you're having, whether it be addiction, whether it be an overdose, whether it be all the things that we see. And now personalized medicine is transcending. It's in psychotropic drugs. It's in pain medications, in cardiac medications. People can bleed to death. I mean, there's a whole host of things we're now seeing. We can now look at somebody, and as personalized medicine develops in different forms, we can look at you and test for you like Angelina Jolie did. with the BRCA1 and the BRCA2 with the breast cancer, and look at that and say, okay, you have a potential now for Alzheimer's, for prostate cancer. And in the future, they'll actually look at those genes and shut the genes down with nanotechnology that will attack the mutant gene and shut it down. These are things we can look at. From this field that we're talking about, we can literally look at that patient and say, hey, don't put him on this medication. You can become addicted to it. You know, I'll give you a story. I tell about this all the time. My father recently passed away in August of this year. My dad was 95 pounds. My dad was a foster child. His parents left him. I mean, he was with a foster family, used to live, and the foster father would beat him up. Quit school in 6th grade to set up pins in a bowling alley here in Newcastle. Got done doing that, left, went to the war at 18 years old. Came back, was a guard at the Nuremberg trials. Came back, married my mom, made 87 cents an hour working at Bessemer Smith. My dad fell, broke his hip, and we had him at Masonic Village. He was on Coumadin. And to tell you what personalized medicine do, he's black and blue from head to toe, 95 pounds. My dad passed away. I did a testing on myself to see. And I got it in the yellow box and the red box. I should never be on Coumadin because I can bleed to death from it. Those are things that we can look at patients in personalized medicine, whether it be from pain standpoint, whether it be from psychotropic drugs, whether it be from cardiovascular drugs, and now predict how they're going to react to the medication before we put them on there. So you may, in some form, decrease the addiction rate, decrease the overdose rate, because we can give the right medication to the patient before we do it, instead of afterwards and saying, okay, that didn't work, try this. That one didn't work, try this.
And doctor, it sounds like that may, and you correct me if I'm wrong, have some value to us. Dr. Capretta can talk to you probably for hours about whether or not a person needs to be on pain medication and how long they need to be there, because it's very subjective. In a courtroom, we call that subjective evidence, and not very little objective evidence on whether or not they need to stay on so many milligrams and whatnot. And so it sounds like that may also have some value in determining how long somebody should be on pain medication rather than just trial and error.
And the dosage recommendations. You can literally look at somebody now and say, hey, we can tell by your metabolism how you're going to break this medication down. This is the dosage you should be on, or these are the medications you should be on or should not be on right now. So those are things that we're looking at in personalized medicine to be able to help eliminate in the future. Now you see huge hospital systems now doing personalized medicine to some form. Mayo Clinic, Vanderbilt University, Scripps Institute, Cleveland Clinic, now looking at every patient who goes on, for instance, anticoagulants or things that they can bleed from, and testing every patient who's having stent surgery. They're now doing this. Harvard University came out with a study on psychotropic and pain medications, and I have this study, and it actually said, hey, get ready out there because this is where medicine is. This is the future. You better get used to it. It's going to be testing the patient and knowing what they can do. You will save not only lives, money that you'll save, and it's really a win-win for everybody. In the beginning, your genes are never going to change. You're going to have that for life. And you'll know, whether it be now or 5 or 10 or 20 years from now, that you should or should not be on a medication that can injure you.
Okay, we're going to pick up again, and we have been very fortunate to have Dr. John Wrightson, who's a permanent member of our staff and our nonprofit corporation, show up. And Dr. Wrightson, as in each of our speakers, we ask that you give your name and your academic background, and then we'll get into some questions that I will ask you, okay?
Sure.
So, go ahead.
My name is Dr. John Wrightson. I am residency trained in both anesthesia and physical medicine and rehab. I am fellowship trained in spine, sports, and musculoskeletal medicine, as well as interventional pain management, and I am boarded in physical medicine and rehabilitation, as well as pain management.
And Dr. Wrightson, you have a practice here in town.
I do, yes.
In Newcastle, Pennsylvania. And how long have you been there?
Oh, probably. I've been at that location for about 12 years now, but I started my practice about 14 years ago.
Doctor, this is about substance abuse, and Dr. Capretta will be answering more questions later along those lines. But substance abuse obviously is not very far from your realities of your practice, correct?
Yes.
And what is it that you have been part of our team for a long time. You've been very concerned about substance abuse. And we know that your patients in pain management are, a lot of them, prescribed narcotics, correct?
That's correct.
Okay, and obviously some people are hurting and they can't go through life hurting. So you and I have talked about this many times. What do you think a pain management doctor should do and what do you do to try to help on this substance abuse issue?
Well, I think the first order of business for any pain management physician is to do a complete and thorough evaluation of the patient and determine, first of all, if they are even an appropriate candidate for the use of pain medication. That's first and foremost. And once that conclusion has been established, from there, then one has to put in place certain procedures and protocols to make sure that the patients are taking the medication appropriately, and to also put in place a monitoring program to make sure that the patients are following whatever the procedures and protocols of the program are, and to make sure that they are not either abusing or diverting their medication.
And again, as I indicated with Dr. Capretta and Dr. Barber, our goal for today in this panel is to create a one-disc multimedia piece that could give somebody a flavor of the big issues. And we know that you did a fine job and a full presentation in our summit, and that's going to be available again in our next drug summit. So hovering above the trees in the big issues, one of the problems is pain management people definitely would have an opportunity to use their medication or convert their medication to other people, people who shouldn't be getting it. We know that. We also know that one of the problems with pain management also is that there's a subjective problem on knowing whether somebody still needs it. Is that correct?
Yes.
And again, I'm not a doctor, and I'm asking you this in general terms. So we once had a doctor who lectured who indicated that periodically he would take respiration rates of his patients and have them sit when their dosages were about to expire to try to always be pushing them down in a dosage. I'm not a doctor. Is that something that has any merit, that type of a...
I mean, you can use that. Rapid respiratory rates can be a potential sign.
And aside from the medical logistics of it, is there a way, or is there a goal of a pain management doctor to try to wean somebody down in their dosage?
Well, the goal is to have them on the appropriate dosage, not to have them on obviously too much or too little, because too little can lead to a condition called pseudo-addiction, which looks something like addiction, but it's due more to undertreatment than anything else. So the goal is to put them on an appropriate dosage of medication, and then to monitor, how the medication is working. And one of the very important items that I discuss with my patient is their expectations with respect to the medication and the amount of relief that they're going to get. And, essentially it's, without putting somebody under general anesthesia, it's almost impossible to get rid of all of the pain that patients might have. So I try to give them a realistic expectation of what amount of pain relief they might have and what is appropriate, because pain is a normal function of life, and pain tells us when we have a problem or not. So there needs to be some amount of pain so that we don't hurt ourselves.
So, and again, going back to this community effort that we're all here rolling up our sleeves in a community, it sounds to me like a good pain management doctor, at minimum, tries to do everything possible to make sure that the medicine goes to only the person who's supposed to get it, and that it's the right medication, and that the person doesn't learn to feel that he has to feel totally pain-free and painless, because we all know that pain, and I'll be the first one if something happens to me tonight to hope there's something that will blunt the pain. Pain is a reality of life, and dealing with pain is a reality of life. Is there a value in the pain management doctor being part of this community effort and talking to an addiction physician too? That sounds to me like that's valuable.
Yeah, absolutely.
And being on the same page.
Yes.
So, great. One last question, doctor, and I wanted to ask you about without getting into your full presentation, I wanted to ask you about this new pain management, this new pain medication that was out, and ask you if you could tell us a little bit about that.
Yeah, the newest long-acting pain medication is a long-acting controlled release hydrocodone called Zohydro. And it is obviously designed to take the place of patients that are taking large amounts of either Vicodin or Norco or any of the hydrocodone acetaminophen preparations to reduce the acetaminophen load that the patients are taking. The problem with the Zohydro at this point is that it is not an abuse-resistant medication. So it is the preparation of the capsule itself is more like the old OxyContin that could be crushed or somehow abused rather easily.
So when you say not an abuse-resistant drug, once upon a time, pain medications have evolved now from being non-resistant to resistant to abuse. And tell me again what a hydrocodone drug is like now.
You mean the Zohydro or just the normal preparations?
The normal pain medication has evolved to what point today over so many years?
Well, the majority of the hydrocodone preparations that are out now have an acetaminophen component, and they're all immediate release components. In other words, you take the medication, it dissolves in the GI tract, gets absorbed into the bloodstream, and then gets delivered to the opiate receptors in the spinal cord and the brain, and that's where they produce the pain relieving, their analgesic effects. The Zohydro preparation, unfortunately, if you do not adulterate the capsule in any way, then it will release its medication slowly over about a 12-hour period. The problem with that, however, is that one can adulterate the capsule so that that amount of medication that should get released over a 12-hour period could actually get released immediately. And especially in opioid-naive patients, that could cause death in the worst-case scenario.
And certainly could be a high stimulant.
Absolutely.
Now, the drug, before this new drug came out, what drug was most often used for pain relief?
Well, there's a number of preparations. I think the one that the patients are, or that patients are most familiar with in lay people, obviously is OxyContin because of all the press that it got.
And how is it that it is now less likely that you could abuse that than 5 years ago?
Purdue, who is the pharmaceutical company that manufactures the oxycodone, actually several years ago, because of all of the litigation and the bad press that they were receiving, embarked upon a project whereby they were going to manufacture the pills in such a way that they could not be easily crushed or chewed or broken or anything along those lines that could then be rapidly abused. So the pills now, you can actually put them on a table and you can hit it with a hammer and you can't break it. They're actually crush resistant like that. So
and you believe that's valuable?
Absolutely.
So the fact is that this brand new drug, now again, I'm a lay person, okay, I'm not a doctor, but I've heard at various symposiums 10 times more powerful, 10 times more addicting. Are those overstatements?
Well, I think it may be a little bit hard to determine the percentage or however more addicting is, but clearly
significant. Can we use the word significant
significantly more addicting than say the new OxyContins are. That's absolute.
Okay, and they are in a form that can be crushed.
That's correct.
They actually go all the way back to the same problem.
That's correct.
So, I have not been able to find an answer. The rest of the panel, maybe when it's your turn to talk, you can help me. I have not been able to find an answer why that pill was released like that. Nobody seems to know. But that's a question for the world. If somebody knows it, please call somebody in our panel.
Well, we met at my office with the Zohydro rep, and I asked her that question. She didn't have a really good answer for it, but what she did tell me is that supposedly they were working on an abuse-resistant form of this. And the impression that I got is that it was sort of a rush by the pharmaceutical company to bring the preparation to market so that it could be used in quote-unquote the right population.
Dr. Barber left, and it's my last question for you. He talked to me off of the panel discussion about, and I wanted to find out if this is possible, that there's some kind of an external application of a pain medication now that's applied locally that shows promise that would not necessarily addict somebody. Am I describing anything that's close to reality? Have you heard anything like that?
There is something called a compounded pain cream, and in these pain creams there can be placed different types of medications, such as Neurontin or gabapentin, for example, which is a medication that patients take by mouth, or something along the lines of lidocaine, which can be used to create a topical numbing sensation, and a multitude of other different types of medications, including anti-inflammatories, muscle relaxants, and so forth, that can be placed in a compounded cream in a form that can be released through the skin into the deeper subcutaneous tissues, that actually has very little uptake in the systemic circulation.
So there is promise in that type of a medication.
Yes.
And because it would be local and not through the digestive system, is it also a medical fact that it would probably not addict the person?
It would be highly unlikely for the compounded cream to cause an addiction problem.
Okay, great. Okay, Doctor, we thank you for coming, and we will take another break. Okay, Dr. Capretta, we're going to pick up only because we're on a strain here. We left off with you on talking about the idea that one size does not fit all. I've heard people express it as one size fits none. So is it a better idea to have an individualized, prescribed, extended care plan? We've already discussed that.
Absolutely, yes.
Okay.
Like any other health condition. I mean, a family physician may see 50 people that day. They do not treat every person the same. Every person should have an individual evaluation, questions about their history, their symptoms, and then treatment should be prescribed based on what their individual needs are, and then they should be periodically assessed to see their progress and need for adjustment of that treatment.
And now, if we go back into that toolbox that we discussed a while ago when you and I opened this program up, we talked about methadone, we talked about Suboxone, and now we've had a very extended discussion on pain medication.
Correct.
Okay, and we know those are all legitimate uses of medication. We also know that they're possibly a problem there in that they're all addicting, both for the most part. Am I right? Generally speaking.
Yes, they're all tools, and like any tool, if used properly in the proper situation as a medicine for the right person, they could be helpful. But if used incorrectly or irresponsibly or too long, they can cause problems, sometimes minor, sometimes life-threatening problems.
And if we look historically, we see that there are references to substance abuse as far back as the book of Proverbs in the Bible.
Yes.
We have references of substance abuse and drunkenness in St. Paul's writings to early priests in early Christianity. But for the most part, medical assistance in treating or pharmacology or medicine is relatively new.
Relatively new. And this is an exciting time because the future is only going to bring us more medicine-assisted treatments. And I know some people who are traditionally weren't used to using those feel somewhat uncomfortable. But until we're getting 100% success with 100% of the people, 100% of the time, we really need to be open-minded and have an obligation to keep an open mind about better ways to provide our treatment. Too many people are dying, too many people are suffering, that we really owe them to give them the best. And it's not medicine versus therapy versus going to 12-step meetings or whatever. It's combining everything together in a comprehensive manner for our patients.
Okay, so, and again, we already talked about the fact that there are multiple numbers of providers out there. Some of them are into some tools and some of them are not. So it probably would be of some value to have those providers being exposed to all the tools and talking to each other and using them all rather than being one.
Yeah, we need more collaboration between, addiction treatment, mental health, the general medical community together. Too long we've been individual silos, doing good work for some individual people, but there's many people who have combined needs that fall between the cracks. And we need to bring more of healthcare workers together, and again, bring the legal system in as a tool to kind of require the person to get the treatment that they need.
So a medical provider should be a provider who is knowledgeable in all those tools we discussed at minimum and willing to work with all of them and all the professionals who go with that.
Right. It's all about what's best for our patients. That should be our mission. Our mission is to help all people affected by addictive diseases to be healthy in mind, body, and spirit. And in order to do that, again, we've got to stay on top of research, trends, and give combined treatments. Again, similar to cancer, you go to a cancer treatment program, they'll bring out the best of chemotherapy, surgery, radiation, other nutritional things. They don't just say, we only do this one thing here, and we don't like radiation or we don't like chemotherapy. And unfortunately, that's kind of the state of addiction treatment and still in many parts of our community now.
And in fact, I was anxiously waiting to jump into that, because that is in fact what we see as the rule right now rather than the exception in addiction treatment. Is it not that some person or entity is methadone, somebody else is Suboxone, somebody else is naltrexone in one of those variations, and many of them are none of the other tools. They are basically, in fact, that's the rule right now, is it not?
That's often the rule. And again, these tools can be of benefit to certain people for a certain length of time, but some of those people might get additional benefit or even better level benefit from using the other tool, or over time moving from one tool to another, again, similar to other areas of medicine. It's getting better. I've been around long enough to see that we're certainly ahead of where we were 30, 40 years ago, but we've got a way to go, and the time has come for us to really, again, take this step forward to work together in a collaborative fashion and bring the best of science, therapy, community services, again, the best of biopsychosocial, spiritual resources together for the betterment of our patients in our community.
And just to give you an illustration of that, methadone is an addicting substance. Suboxone is itself an opiate, is it not?
It's an opiate. They can all cause physical dependence. Now, there's a difference between physical dependence and addiction.
Right.
Anybody on these medicines, physical dependence basically means that you develop a tolerance, and then if you stop it after you're on it for even more than a couple weeks, you'll have withdrawal symptoms. That's not addiction. Addiction is when you have out of control use. Now, I realize we throw that around kind of as a layman's term, that it's addictive, meaning the same as physical dependence, but there is a difference between the two terms.
Okay, and I definitely acknowledge that, and
Yeah.
I'm guilty of that too, because
and I
I'm
am
not
too.
a medical person. However,
And we all
there
say
is
that, yes.
definitely a dependence that would
Correct.
go along with methadone and Suboxone.
Correct.
And then when we go to this other pharmacology, which is the naltrexone variation, that, unlike methadone and Suboxone, is not something you would develop a dependence on or an addiction.
No, that is a blocker. If this is your opioid receptor, think of it like a catcher's mitt, and a person is used to putting, Oxycontin, heroin in. They're like opioid baseballs that fill it up, and every time it hits, it causes the opioid filling. The methadone and Suboxone also go in, but they are more controlled forms that last longer under a doctor's prescription. And actually, the Suboxone has a blocking element that keeps other ones from coming in. The naltrexone is more like it doesn't go in, it just blocks the receptor. It's like putting a wall in front of it. So if somebody tries to use, it hits this wall, it can't come in.
The one would be a partial antagonist, and the other one, the naltrexone, will be a full antagonist.
It's a full antagonist. Buprenorphine is a partial agonist, as we say, an antagonist, and methadone is a full agonist. These are technical terms, and I apologize.
And I want to take advantage of that catcher's mitt imagery. It's in my head right now, and you're painting a picture with your words, which is wonderful. That's what we try to tell a witness to do. So I have my catcher's mitt here, and methadone goes into the mitt like a baseball.
Right.
And it is not an addiction, but it certainly is a dependency. And my Suboxone goes into the catcher's mitt. Again, generally speaking, a dependency, although not an addiction. And the naltrexone literally wipes the pocket out of the mitt so nothing gets in there.
Right. You got to make sure that mitt's empty before you start it, because if
Okay, I
there's
was gonna
anything
get
in
to
there,
that.
it'll scoop it out. So you have to be opioid free for 7 to 10 days.
Definitely want to go there.
Yeah.
Because although we might be wanting to say, yay, naltrexone, we also know that the naltrexone blockade probably, from what I'm told from doctors, cannot be administered for at least 7 to 10 days after a person has been totally abstinent. True or false?
That is true. It can be, but you'll make the person very sick. You'll throw them into immediate withdrawal. It's basically a longer-acting form of the life-saving medicine given by paramedics in emergency rooms called Narcan or naloxone.
Okay, so if we go back to this together movement here, and that's what this is all about here, this togetherness. If we go back and start pulling this together, the naltrexone person who wants to play a role in treatment of a methadone or a Suboxone person needs to cooperate with that methadone and Suboxone person, and vice versa, because I can never apply my naltrexone until I have brought this person down to a total abstinence for a series of days. And by the same token, if I want to make progress with my methadone person and take them toward total abstinence someday, I need to get along with the naltrexone person. So in all of that, have we not identified an amazing and vital importance in all three of those people to be talking to each other?
Absolutely. They should be talking, and hopefully good providers are trained to provide all these services, and if not, collaborate. I really think patients who are on medicines like methadone, buprenorphine, Suboxone for whatever period of time they need to stabilize their life, I think the majority of them should be considered to be transitioned to naltrexone for maybe a period of 6 months to a year afterwards, to give them that added protection of that blockade without the physical dependence. I think you'll see better results if you do that. And again, while you're doing all of this, you still provide them with support, counseling, therapy, get them involved with 12-step meetings, and the whole ball of wax.
And I was going there too. You're like one step ahead of me, and it's like we rehearsed this, but we did not, by the way. Overlaying all of that, that's medical assistants, that family of pharmacologists.
Yeah.
Okay, overlaying all of that is the talk therapy. And we know that there are some traditions out there that say no medical assistance with talk therapy. There are some people who teach that, okay, and we're not necessarily agreeing with them, but we have to overlay that with the counseling, because as you indicated, there's a person is a total person. He's a mental, physical, spiritual being, and so we must address and use every one of those tools too, and that's why that counseling is very important all along this journey, correct?
Sure. We're treating human beings. We're not treating a computer with a virus. Medicines can be very helpful tools, but people have lives, they have relationships, they need coaching, counseling about, our terminology is people, places, and things. What things trigger you? What should you avoid? And it's amazing how people, even very intelligent people, can have blind spots in their life when it comes to addiction. Some of it is just due to the denial or minimization, and they really do need counseling, and often group therapy is a very powerful tool to get involved with other people recovering who kind of see what's going on. There's the old saying, you can't con a con artist, and people with addiction often know the tricks of the trade, and they can call out one another on some of their minimization and defense mechanisms.
And before I go to our counselors here, again, going back to that other piece, that lawyer, that law piece that falls on top of this. And remember, we talked about that in terms of a large group of properly motivated patients, and now the ability to make extended care binding. We as lawyers As a lawyer, I can tell you, I've been in 32 counties in Pennsylvania and multiple states, and I can tell you when we walk into a courtroom, we will walk into a courtroom in which there is no drug court, no DUI court. Somebody might say, well, that's bad. That's actually better for me right now in the status of those institutions, because I can make my treatment argument with information you have given me. Okay, now I also run into places where there is a drug court and there is a list of disqualifiers. And if my client doesn't fit in those disqualifiers, however much he might need treatment rather than incarceration, I have to work twice as hard to get him or her there. There might be another court that has a DUI court separate from drug court, where they keep them separate. For some reason, they seem to think an alcohol person, and David Sproat will be talking soon here. He'll talk to us about alcohol more, where an alcohol person is separate from a drug a dependency issue on that. So as a lawyer, I run into all of those situations, and what we also do is we find state penitentiary. There's two tiers of incarceration. Number one, I'm trying to get treatment, not incarceration. But then we're trying to keep treatment at least local, if not, because if not local, we go to the state penitentiary. And I have to tell you, for the most part as a lawyer, I'm not a doctor, the state penitentiary does seem to have a one-size-fits-all attitude about substance abuse treatment. And the other problem I'm finding in drug courts is that sometimes the judge is forced to play the role of a doctor because the lawyers are not talking to the providers and not sharing information. The court is left to look through some little piece of paper that was faxed by a doctor saying Billy Bob is in treatment, and that might be an overstatement as to what the judge had. And the judge is sitting there with a law degree. He's a judge. He's usually a gifted jurist committed to his community, but he's trying to create a medical solution from that base of knowledge. So now if the lawyers are helping the judge by advocating on one size fits none, my client is a person. I have talked to Dr. Capretta, I have talked to Bill McLaughlin, I have talked to Nessa Wilson, whoever, I now have a document that I can submit to the court that's general, but an extended care plan that for now should be made a binding order of court. Is that not valuable?
It's very valuable.
It takes the place of the judge having to become a doctor.
Right. I mean, you're addressing the appropriate needs, and you're going to get better results if you do that.
Right.
It's shoes. I mean, if again, one size doesn't fit all for shoes, and one size doesn't fit all for the addiction treatment needs of a person. You put on the wrong size shoe, you're going to get blisters.
I may be tempted to expand upon that argument, but I'm not going to, because I think it's a perfect segue now to our two counselors who have been sitting patiently there, because not only do they do this, they've been doing this for quite a while. So Doctor, we're going to take another quick little break here and move the mic. Okay, now we're also fortunate to have Bill McLaughlin with us, and Bill is a member of the Lawrence County Drug and Alcohol Commission, correct?
Well, actually, I'm a member of the Lawrence County DUI Advisory Board.
Okay.
And I work at Human Services Center full-time.
Great.
And do private practice part-time.
And I just scooped you there. Your name for the camera, please, and some of your background, even if you have to repeat that.
Sure. My name's William McLaughlin. I have a master's degree in educational psychology. I became a certified addictions counselor for the Commonwealth of Pennsylvania in 1987 and a licensed professional counselor in the Commonwealth of Pennsylvania in 2002. I've actually been in the mental health DNA field since 1975, so that's 39 years as a frontline treatment provider. And I currently work for the Human Services Center in Newcastle, Pennsylvania as the forensic liaison, which has me in and out of the court looking at possible treatment services for people prior to sentencing. And so that's kind of where I'm at this point.
Great. And you and I have worked together and shared information and research, and I can't tell you how much valuable information you have given me throughout the several years. I think we have been working together, 2 or 3 years now?
Close to 5.
Close to 5.
Close to 5, yeah.
Okay. And I certainly am a better person for it.
Thank you.
I respect your work immensely. And I've actually been in and out of your counseling sessions sometimes when I've had a client that I refer to you. And the one thing I have to say that you're a counselor who tells a client and a patient what they need to hear, which is sometimes different than what they want to hear. And you're always pushing them toward progress. And I think that you're a gift to our community, and I don't mind saying that
Well, thank you.
on our dais here. Mr. Bill, question. You've heard a lot of these conversations now. So I'm dying to pick your brain a little bit on what we see the historical development of this pharmacology, this medical assisted treatment. And we're not here to bash methadone, or we're not here to bash Suboxone, or bash anything that's trying to work on this problem. And we hope nobody takes it that way. But one of the problems that probably contributes to this, it's an opinion that you may or may not have, is the idea that these things have come along in stages. For example, I think antabuse goes back clear to 1994 or something like that, or maybe even 1980.
It goes back 60 years.
60 years.
Back in the
And
military, I think, in the Navy in the 1950s and 60s, yeah.
And it seems to me that there's a story, I don't know how accurate it is, that it was developed by accident in Akron, Ohio, from the fumes of a rubber factory or something. People drinking beer. There was a relationship to the... Anyway, the bottom line is the antabuse, somehow, and again, I don't want this to be a medical thing where no one understands what we're talking about except the doctor. But generally speaking, the antabuse makes the body think that it has overdosed on alcohol or formaldehyde even, and actually goes into violent dry heaves, we call that. Am I saying that wrong?
No, the antabuse, what it does is when alcohol breaks down ethanol, it breaks down to what is called acetaldehyde, which is the second stage of the breakdown. First stage of the breakdown, actually. And if anybody drinks too much too quickly and they feel a little queasy, their acetaldehyde level is high. Well, the antabuse locks that acetaldehyde level in, and so you don't go to the next stage, which is acetic acid, essentially vinegar. And because of that, that's what causes the person to become sick. The idea behind it is if it's an antagonist, people don't want to get sick, they'll take it, it'll work. My experience has been for a relatively non-alcoholic person that might work in terms of being a motivating factor, but I've sadly known alcoholic people that were put on antabuse and continued to drink on it and got sick but just drank anyways because they were so chronic and compulsive. One thing you brought up I'd like to touch base with about the historical overview. Being I've been in the field for so long, I can remember back in the late 70s working for the old Lawrence County Council on Chemical Abuse, and there was a gentleman at that time from OVR who wanted to send a patient of his to us for evaluation to go to an inpatient program, which was Gateway Rehabilitation Center. And this individual had epilepsy and was on phenobarbital, which was a standard medication to treat the epilepsy. And I can remember having to speak to the medical director at Gateway to get permission to admit them because they were on a medication. And back then, it was very cut and dry, abstinence only, okay? And then about 10, 15 years later, I was at a training at Gateway, and there was a young psychiatrist named Dr. Capretta, and he was talking about these new medications that were being, issued at various inpatient programs for people that were dual diagnosed. And he mentioned terms like Buspar and Wellbutrin, and I'd never heard of those before, but he said they seemed to have a really good track record with people that were coming out of inpatient rehab that had both issues with depression and chronic alcoholism or drug dependence. And I remember Neil saying that it gave people just a jump start on their depression, that if they could get 6 months clean time with the aid of the medication, that the effectiveness of the treatment would be so much greater because usually people relapse within those first 6 months coming out. And that was almost like a new wave of medication at that time. And now here we are 20 years later talking about Suboxone, methadone's well established, the Vivitrol injections, naltrexone. I think a lot of inpatient programs now will make naltrexone mandatory, or not mandatory, but recommended as part of their aftercare plan to kind of cut down on the prospects of relapse. So over those 40 years, I've seen the DNA mental health field, which totally distrusted one another and never worked together. Now you've got the medical perspective, the medical field in, and it seems like there's a lot more communication and cooperation. And that's why I think what we're doing here today is so important, because it was almost like the dark ages back in the mid-'70s when I first started, and now I just think there's a lot more tools in the shed to work with, and hopefully the results will get better.
I can't help but say, as a personal observation, and even what we're doing today, I look in the faces of each of you, and I watch the medical people looking back and forth to each other, and you know they're dying to ask questions or talk more to each other. And it goes back to this idea: what is a lawyer doing standing in here? But that's to me, and I can't help but throw this in here again, and we'll get to Dr. Iacino for a minute. If you quote Isaiah, "Come, let us reason together." We don't know if we have all the answers, but it's important for us to begin and maintain a dialogue. And the legal, medical, educational parts of a community is the community. And when we come together like that, they will come together. When they come together, good things happen. So I love that historical perspective. Now, jumping ahead, though, into your counseling area, we do know that historically there are some people who to this day advocate this, and it was a lot stronger once upon a time, where it was talk therapy only, right? In fact, you were not permitted any kind of medical assistance. And that goes back into a lot of this therapy issue. And now we've come to what we call counseling. So I'm assuming you're sitting here in this body and you agree with Dr. Capretta that counseling and medical assistance treatment can work together, and in fact should work together.
Absolutely. Neil made the point that there's a difference between physical dependence and addiction, and I think he pretty clearly articulated those differences. I think there's also a difference between abstinence and recovery. I think abstinence is getting the person to a position where they're drug-free based on whatever their drug of choice might have been. I think at that point in time, the therapy team gets a chance to take a look at what they have to work with. Using the examples of Suboxone, I have a couple of patients who are very high-functioning individuals that got addicted to synthetic opiates, went on Suboxone, and they do incredibly well. I mean, they're working every day. They take good care of their families. If you didn't know they were on Suboxone, that would never even cross your mind. So there's a lot to work with there because they are so high-functioning and able to solve their life problems. And then there's folks that are on Suboxone and they don't have those kind of skills. They're not that motivated. They don't have the supports that the individual does, and they tend not to do nearly as well. Sometimes they don't stay in the Suboxone program because of the lack of support and inability to stay away from high-risk people, places, and things. So I think what you end up with once you get a period of abstinence established, you find out what you have to work with the individual, and hopefully the treatment team can come up with a treatment plan that is specific to that individual.
And you just said a word here I cannot let slide: treatment team. Team is equal members of, but they have their own turf, and but at the same time they do play together. We always use the analogy of a team, or even a symphony orchestra. Some of the most gifted musicians in the world, if you put them on a stage and gave them their instrument and they played whenever they want, whatever they want, you would have nothing but noise. But if we have standardized sheet music and somebody directing who's playing the tuba when, we now get this coordination. And that takes me precisely to what we've coined a phrase in some of the years we've been working together, and I don't know if you use this term or not, but I call it, for lack of anything else better, coordinated counseling. And the way when I say coordinated counseling, I'm talking about a person who is counseling, the addiction issue, but also almost kind of like a liaison between and among all these professionals, because as the doctor indicated, we have a disjointed industry right now. There are a lot of people who are out there and they might be going to a different address for the methadone that they'd be going to for the counseling, just because. So is that what your concept is of coordinated
Absolutely.
Counseling?
You used the term an opportunity when a legal intervention takes place. It's an opportunity for the identified patient to make significant life changes, whether it's done directly or indirectly, that can benefit them and their family. And an example comes to mind. I had this gentleman that was originally sent to me several years ago because he had multiple DUI arrests. And his probation officer basically told him that if he tested positive for marijuana one more time, he was going to, actually had one DUI arrest, he was going to lose his ARD status and have to go to jail for a few days. And he was sent to treatment because of the positive urine test that the probation office was able to collect. And I remember he was very upset about that and felt that it was intrusive and it wasn't really related to the original crime, etc. I said, well, let's just do what you need to do to stay in compliance. And within a month or so, he comes in, is all excited, and he told me that he had applied for a job. He was called in for an interview. The interview went well, and he went down to the medical department, and he passed the urine test, and he got hired. And I remember looking at him and saying, that's great news. I'm glad for you. And on the way out, make sure the next time you see your PO, your probation officer, you shake that person's hand. And he looked at me, he goes, why would I do that? I said, because if they had not forced you to come down and talk to me, and if we've not worked on these issues, you're not employed right now. So indirectly, he or she did you a favor that's going to benefit you, your wife, your kids, etc. And when I explained that to him, he kind of looked like, yeah, maybe I should say something. I said, hey, it all seems like it's part of a bigger picture sometimes, but we just can't see it. But that always comes to mind, that intervention, which he really wanted nothing to do with, benefited him because he was able to comply.
Wow. And then there's another level of coordinated counseling, a safety level. Dr. Capretta talked about the naltrexone, the catcher's mitt, and I'm going to always use that now from now on. I will footnote it properly, doctor. But the catcher's mitt doesn't have a hole in it anymore. There's no pocket to catch the drugs. Okay, that's what my case. I have a catcher's mitt that's not going to catch anything. But if I can't catch anything that used to help me because I have some deep-seated mental issues, where I was self-medicating, maybe abusively, but I was self-medicating, is that not another reason why coordinated counseling would be important? Somebody like you should know if a person is blockaded with this naltrexone, or am I wrong?
No, I agree 100%. With the recent drug overdose of the cast member from Glee, I can't recall the gentleman's name, there was various talk shows, nationwide talk shows, and this one addictionologist got on and said it was really sad at a time when there were these other alternative products, and they mentioned directly naltrexone and Vivitrol injections, and they talked about how opiates hijack the brain and create cravings and obsessional thoughts that never existed before, and this was a one tool that could possibly have helped had it ever been used. And I just thought that we've come a long way from everything has to be completely drug-free, and it seems like our thinking has become a little more liberal, okay, and all, encompassing that, hey, we've got to look at whatever options work best for people in terms of that individual treatment plan.
And the last value I see to coordinated counseling, and I'm saying this because I've seen it, people taking the naltrexone, most of us have a medicine cabinet that have an unused prescription, even a cold medication or something, that you feel better. What do you normally do? You don't take the rest of your prescription. And we see that with naltrexone. I've seen it, but I'm only a lawyer. I'm asking you as a counselor, is it possible that a person feels so good that they just quit taking that sooner than they should?
I think that's a common mistake that many patients make, that just like you said, if you use the analogy, I don't have the cold anymore, I really don't need to do the same things. I don't know that a person would need to be on naltrexone for life, but it's something they need to coordinate, again, with the therapy team, particularly the person that prescribed it. How long do you think I should stay on this? And take a look at, what other supports do you have in your life should you get off of it? Is there enough recovery momentum there to carry you through? If you rely solely on the medication, generally, I think you fail. If you've added things to it in addition to the medication, it gives you a very good chance of turning the corner. But that's something perhaps Dr. Capretta could address, like how long would he recommend a patient staying on based on some of those things. But again, that treatment team concept, that's something you need to discuss with the person that prescribed it, and don't end the treatment before it's been most effective.
And I'm standing here saying, yes, and I want to be on the treatment team and be its legal advocate in front of that judge, so he doesn't need to be a doctor. He can hear your voice through me and your documents so that we can move this person, the properly motivated person, to an extended care plan that is most often designed to work. It's certainly better than one size fits none. Okay, that said, and we keep on using this word team, I cannot, and I won't, pass up this opportunity. I'm in front of Dr. Iacino's student body, like we all have been, and we will be again on April 25th. And one of the things I asked the children is, how many people know anything about World War II? And of course, a few hands will go up. and I'll ask him what was the deciding moment, what changed World War II, what changed the complexion. And those of us who study that know that it was the entry of America into the war. It was the America becoming an ally. And this is where I think we're at I would not be optimistic enough to say the beginning of the end, but I would borrow Winston Churchill's phrase and say maybe we're at the end of the beginning at least. And we can say now that we are now, adding probably the most important ally there is on the war on drugs. The patient. Where with this pharmacology and this coordinated counseling, we are empowering him and her to be a co-equal ally in this war. And if you want to make some real progress, now we can really make some progress because we have the right ally. So, using that word team and using that word group, we also know that groups exponentially increase the possibility of chaos. Even professionals, and sometimes mostly professionals, don't necessarily play well on teams. So we're going to take our next break and go to Nessa Wilson, who will talk to us about coordinating the coordinators and various things we're doing with technologies now, and that'll take us right into David Sproat. And we will have Dr. Iacino tell us how he's inspiring the entire community on what is a very good message that we're getting today. Okay, Nessa, it is nice to see you again. We see each other at work quite often. And I would ask you to introduce yourself to the camera and the people who are watching this today, tomorrow, and whenever. Again, your name and your background, and then I'll get into some questions.
Name is Nessa Wilson. I have my first master's degree in social work from Pitt and a second master's in business administration from Western International. I'm a licensed clinical social worker and been working in the mental health field for about 14 years. I do both the individual counseling with teenagers and adults, as well as work to set up and coordinate with some counselors that work with me and the different organizations or agencies that they end up working with.
Bill has worked with you for a number of years, correct? And you share with him his opinion of coordinated counseling, and I don't want to reinvent that wheel. Is there anything that you think we've missed on that we should add to that?
I think coordination is absolutely essential. The only thing I would say that you really want to include and coordinate with also is going to be the family and the support system as well, not just all of the different medical professionals and legal professionals, because family members themselves end up being, whether it's the biggest tattletale to the family or your biggest advocate to make sure that you are getting all of the ducks in a row. They're going to the appointments from lawyer to doctor to therapist, and they're a lot of times helping report things that the client themselves might forget to tell the doctor or to tell the person that they're meeting with that day. Because lesson learned is when somebody is going through addiction treatment, in particular when the legal system is involved, is they meet with lots of different people, often multiple times a week as they're going through the whole system.
And not only is that a challenge, it's an opportunity for an addict or an alcoholic to kind of hide behind people and frustrate the process too. So we definitely want to make sure everyone is on the same page. And that's where we're going with your presentation. But I want to step back and recall how many hours you put into reading a document we created once upon a time called a behavioral modification contract. And the proofreading you did, the expression on your face right now tells everybody how much proofreading was necessary. I think we ended up with about 140 some paragraphs. And I would ask anybody in this room, including members of our panel here, what's the most popular song that there is in the United States history that has made more royalties than any song ever?
I don't know.
Does anybody know that quickly?
White Christmas.
Very good. You've been at my class before. I could count on you, David, to do that. No, but it is actually kind of neat to get the answers because it reveals the age of the person, too. The answer is Happy Birthday. If you go into Chi-Chi's or some other restaurant and they're singing Happy Birthday and you're wondering where they came up with that rendition, they have to do that because they would have to pay royalties if they were singing the real Happy Birthday. Now, the point of that is you knew that. You just didn't know you knew that. So the behavioral modification contract is a codification of good things that a person should do life-wise. Okay, things that everybody knows. Well, I know that, but I'll bet you never signed an agreement to do it before, though, a legally binding contract. And the behavioral modification contract, if you recall, we put several key elements in that. One, a person needs to be in school or working, correct? Okay. Number two, the person needs to have an association cleansing. She does not run around with people who abuse. 3, they follow all their doctor's appointments and structures and whatnot. 4, they're periodically tested and whatnot. In many ways, that behavioral modification contract is much more stringent than any court order you would see. And it's designed to tap into spiritual, mental, physical, family assets, everything we can bring to the plate. And it's always, and I have to commend you for this, you always have the family of the addict, alcoholic with them, because you are telling them they're part of the process. It's a multi-party contract too, where that family member is a liaison tattletale if necessary, because that person's going to see those precursors in that extended care sooner than somebody else. So that's a very powerful part of your counseling, correct?
Well, absolutely, because unfortunately one of the, I don't know if we want to call it a strength, but one of the strongest points with people that are in addictions is that they can be fabulous manipulators and able to move things around to the way that they want them to be seen. But having things very stringent, very laid out, and having everybody else working on the same page kind of decreases a lot of that splitting and being able to play all the parties against each other.
And reducing it to writing. And again, I am a lawyer, and I am telling you this is an area of expertise that I am comfortable in telling you, doctors and medical people, educators, that a good contract is one that never is seen again after it's signed. People remember what they agreed to. And a good contract like that made into an order of court is the doctor's best friend, because provision 1 in that contract says that he or she shall keep all of their appointments, and that would be a breach of a court order to actually entitle them to be revoked and actually put back in jail if necessary, because those precursors are red flags to a relapse that might be coming and whatnot. So that's probably another way of saying that it's really good for a lawyer to be working with these doctors, because your extended care plan is incorporated into that binding contract, and it's signed off by the district attorney, it's signed off by the adult probation, the judge, and everyone else. And most importantly too, I have to tell you this for those of you who are into accountability, and David, you're an experienced veteran of the court system, it is a contract that is created on the anvil of litigation. And the imagery I'm trying to draw up is a hammer and a hot iron being pounded with iron and metal, and the district attorney is standing right next to you, making sure that this is something that is valid, not some little gimmick to get somebody to keep out of jail. So by being an advocacy-based product, it actually will be something that's dependable and reliable, not just a candy coating for some wealthy person to avoid jail or something like that. So when you bring the legal community into this, it creates all of that, and Nessa helps. Now, going back to our original point, all of those people, all of those instruments, all of those egos on the stage and whatnot, and they're all out of control. Tell us how you've managed to accomplish putting some system together, including use of technology.
Well, I guess one of the important things is for all the people that are working in the system to be able to at least start with some face recognition for the other people that they're working with, so that they know, okay, this one is seeing Dr. A and he's seeing Dr. B, and you know the styles of the clinicians that they're dealing with, you know how they interact, so that when you do go to work with them, they're a lot more likely to work with you.
And you've got all those HIPAA issues out of the way because you've passed those releases around between and among all these independent professionals. And there's some logistical issues. I guess you're referring to what you guys call your e-chart. It's literally an email. And it goes round robin to the people approved on that release form. And everybody can see Billy Bob was at my office 2 weeks ago and he looked good or something. I'm just creating a little, is that what we're talking about? I mean, we can use the technology of internet delivery systems now.
Again, you have to be very careful
Secure.
with that because everything has to be secured email, everything has to be encrypted.
That's a given.
HIPAA is a very powerful oversource that sometimes makes things more complicated in an attempt to make them better. But there are a lot of systems in, I guess, media and technology out there that is really doing very good at working its way within the HIPAA system down to electronic and video-based sessions for people that have already been seen and have been able to prove that they are at a reliable level. We've actually been able to do webcam-based sessions on specific situations with a client who might be 200 miles away, who we wouldn't normally be able to keep updated, let's say whether they're going out of town on a sales meeting, which might be a whole lot more opportunity to have a relapse because they don't have their supports around them. Or you rotate, or you have to come in every so often, but then we'll give you some leeway depending on how you're doing with your drug testing, and then we keep the coordination going with the doctor and with the probation officer and with the different systems involved just to make sure that they're doing at their best level in all of the different areas.
Which is wonderful. You're doing great work on that. Okay. Is there anything I forgot to ask you that you wanted to say that you wanted to make sure we develop? This is a perfect segue into our next to the last person, David Sproat, who will tell us about some technology things that are really exciting, doctor, for therapy purposes, especially in alcohol. And David, I will give you the same, we'll take a 2-second break while we move the mic. Okay, David, welcome and thank you for coming. You and I have been hanging out in this endeavor for at least 7 or 8 years, huh?
At least.
Yeah. And I will ask you the same question because we want to make sure that we have a good record here. Would you please give your name and your background and your company and those important issues to the camera, and then we'll start.
Oh, thank you, Angelo, and thank you for inviting me to participate in the panel discussion with the distinguished speakers. I consider myself probably the least distinguished, but maybe the most senior. But my background is in epidemiology and microbiology. I have a master's degree from the University of Pittsburgh Graduate School of Public Health, and I've been working as a clinical microbiologist, clinical biochemist since 1968. And I've done almost every form of alcohol testing from that time till present, from the initial chemical analysis that Bill mentioned earlier and the breakdown of alcohol, all the way through current technology that uses near-infrared technology to directly measure alcohol through the skin and give an immediate readout. But I'm here to really talk about what I've seen in the last 8 years in using these tools that you see before us. If you will, these are eyes for the court or the treatment provider to determine if an individual is compliant and following treatment. They're used by the court on this end as a continuous monitoring for alcohol to make sure that a person does not use alcohol by court order. You mentioned Judge Barrace earlier. He has about 400 people a day on this system. Over on this end, we have a device that treatment providers use. For example, we're using it currently for a high-profile case in Westmoreland County under the direction of Westmoreland County Court, where we report the results of an immediate alcohol test so that a mother can visit her children and we can document immediately that she is free from alcohol. Ongoing, I can tell you that that same individual was in treatment with her, in counseling with her husband this very morning. But 3-4 times a day, she'll blow into this. Think of this as an interlock, but a personal interlock that goes everywhere the individual goes. So we can assure the safety and the compliance that this individual, during the time that she has her visitation, is not using alcohol. And yes, she is on the addiction spectrum on the far right. So it's very important to all, the treatment and the court, that the individual is free from alcohol. So,
and David, can I interrupt 1 second? Because
yes.
I want to tell you how I would take off with that if I were a lawyer. I'm in court with a lady who's separated from her children. Children are traumatized by that. Mom is certainly traumatized by that. It's not a good thing to totally separate those kids from this, but it's also less of a good thing if she would be in a car and kill those kids or kill somebody else driving.
Certainly.
So I now, as a lawyer, am empowered to tell the judge, and Your Honor, the one thing you're afraid of, I can make sure it won't happen because my client will have that device and she will be tested, right?
Correct.
So tell me what I can tell the judge that he can depend upon from that.
Well, this device can provide not only that the person is free of alcohol.
It'll be in
at
her
that,
purse?
It can, yes, it can be carried in her purse and in the car. But when she leaves her car, she has an interlock device, and we can assure you that she's not driving under the influence with the interlock. But what happens when she leaves and goes to visit the children at the farm down in Westmoreland County, and she's away from the car for 2 or 3 days? We can assure that she's not using. Correct, and she could do that as well. With this, personally, she now must test. And it does have a GPS signal, so we know where the test is done. We know what the quantitative alcohol value is. And it also has military-grade facial recognition, so she can't use someone else to take the test for her. So these are kind of the technologies that are an adjunct to treatment that can help you, as Bill points out, assure abstinence. This certainly doesn't treat and it doesn't cure.
But it does monitor.
It does indeed, and it allows you now to have eyes into what your client or your patient is doing while they're out on their own in the world, working and with their families.
Now, I want to, again, only for the sake of jumping on these bigger issues here, please bear with me because I don't want to miss these moments. Certainly, that's cheaper than putting her in jail for the taxpayer.
Certainly, it's less.
Certainly, it's cheaper to her than losing her job because she's in jail. And the reason we're going to put her in jail, supposedly, is to keep her from drinking. And this is going to, it's better than having her on house arrest, because on house arrest she could drink 5 cases a minute and no one would ever know.
That's
right?
exactly right.
So,
just for example, last week we had a local student on this through one of the local county's court programs. And she used it on a Saturday night, and it returned an immediate value of 0.502. It's one of the highest alcohol levels I've ever seen where someone wasn't passed out and going to the emergency room. We thought it was spurious. So the device does another test in 10 minutes to confirm, sent the results in immediately, and it was 0.49. So when the individual was called in and they visited her, they found that she admitted to drinking, of course. We asked her how much she had consumed. She had consumed a full 1/5 of vodka on a Saturday night. And the reason I mention this and what I'm concerned about, I'm not only a businessman and someone who's interested in recovery, but I really am concerned about binge drinking among students particularly. And we're seeing that kind of drinking. Now, how does someone get to a 0.5? Well, if you drink Monster or some sort of stimulant as well as drink alcohol in that volume, you can achieve these high levels now, which are near toxic. So this kind of technology can help now with monitoring students, family courts, and it gives a flexibility as a treatment adjunct.
and David, you sat here and listened to Dr. Capretta. Dr. Capretta wants to transitionalize somebody into extended care and actually put them on recovery. This could be used. There's nothing that says it's only for the court, right? The doctor could use that if he wanted to use it as a monitoring device for his patient.
Well, absolutely. Dr. Capretta mentioned I believe it's the biopsychosocial spiritual nature of what we need to do in a coordinated effort. And I think these kinds of technologies can work well as an adjunct. For example, biologically, this is all about getting the molecule of alcohol out of the system long enough so that traction can be made with other treatment essentials. How does it affect psychologically? It's probably how it works, frankly, why it's successful. An individual who is in alcohol addiction on the far right spectrum can't stop despite the consequences, as you pointed out. Well, this lets them know that if they do drink, you'll know immediately and something will happen, an intervention swiftly, which can be further treatment, or in the case of the legal situation, a sanction, and it can now get that person safely into a more intensive treatment program. So it's an assessment tool, essentially, along with the psychological benefit.
And although this is mostly alcohol, we do have that problem that it is legal to drink alcohol if you're 21. And you can drink as much as you want despite the fact that it is unhealthy to do that. It is only illegal to drive a car and drink alcohol, other than the age issues with kids. So we're fighting an uphill battle by always pushing alcohol to the side, that it's okay to do that. And although we're now not talking so much about the legal system, and Dr. Capretta, it is my experience, and it may not be a valid one, but I have observed many people go from drugs to alcohol because they think it's okay to drink alcohol because that's legal.
Oh, absolutely. In
So
the court
now,
systems.
if we're really trying to push somebody to recovery, I think it would be simplistic for us to ignore the alcohol component.
Well,
and these devices can be used for that.
I think you're absolutely
tell
hitting
us
the.
what that device does.
You're hitting the nail right on the head. One of the local counties in central western Pennsylvania uses this device in drug court. And I was fascinated. Why are you using it in drug court? Most other counties, DUI court, and for pretrial primarily. And they said, well, the reason is we do drug test them regularly. We know and we can watch and monitor. But what we're finding is when an individual shuts down on drugs, then they often revert to the more readily available alcohol as the drug of choice. And so they put this on to assure that they are remaining abstinent throughout the entire process. So it works very well. But to answer your question, how does this work?
Yeah, tell us a little bit about
this. I'm not going to mention the device itself. Let's call it a continuous alcohol monitoring bracelet. And what is it? It's a breathalyzer strapped to the leg, calibrated to measure alcohol as it comes through the skin, transdermal alcohol. It's been proven in the court to be scientifically acceptable as a technology. And for the last 8 years, I've seen anecdotally and empirically, it's had great impact on the clients that I work with. I respect every single person I put on it because I know they're on the road to recovery. I'm just a provider of a electronic technology, a tool that's going to help them get along that path a little easier, I believe, and meet the court requirements. But what I found was individuals who are on this 90 to 120 days seem to have an amazing turnaround. First noticeable in their countenance, the appearance on their face. Usually when I put this on, an individual will be angry at me, the judge, you, and everybody else. 3 months later, 90 days of abstinence, I've been hugged and I've been apologized to, and it's the best thing that ever happened to me. I didn't realize what I was doing now that I've been alcohol-free. And I said, well, why were you alcohol-free? And they said this buzzes every half hour in a very slight way. It'll sound like your phone vibrating. And they tell me that that's a reminder. And after 3 days, they don't even know. It's like a blind spot. They don't even see it. But they tell me that because of that, they know there's a constant reminder that if I do decide to drink or want to drink, somebody's going to know about it. And it seems to make all the difference in the world in getting through that 90 days. The magical moment is about 90 to 120 days. If you get the molecule of alcohol out of the body long enough to where cognitive decision-making can be repaired by what you do in treatment, then you have a chance of really having long-term effects. What are the long-term effects? I could never say this before. I saw it anecdotally and empirically, but this is a published study from North Carolina that shows that when you compare a group wearing continuous alcohol monitoring to a group not wearing continuous alcohol monitoring, that recidivism is cut in half at 3.4 years downstream. Being that I have a background in epidemiology, it kind of caught my antenna went up, and I said, wow, that kind of supports what I've been seeing. So what we know is that this is just an electronic technology. It's not the answer. What you do is the answer, I believe, all together in a coordinated fashion. But this has a significant role on this end for the severely alcohol addicted, on this end for the alcohol abuser.
Now, I want to jump on that word you used, traction. Mm-hmm. If I were speaking to you and I started mouthing my words but not saying anything, you would not hear what I'm saying. Okay? We call that white noise sometimes. So is that what you meant when you say traction? When we get somebody totally abstinent from alcohol for a period of time, they may now for the first time be hearing what they had been ignoring under the influence of that long-term.
I think that's part of the self-discovery that they have had a problem. Now, and it usually is by way of feedback to not only from the individual, but from their spouse, or someone that they are with saying, it's a new person, thank you. I mean, that's really gratifying to see.
And and now I have to take advantage of this little personal thing that you and I had. Years ago, we worked on a case, and it will be coming up on Easter again. And every Easter, I remember this case. That we had a gentleman who was in prison for seriously injuring a child. It was terrible, terrible case. He was under the influence of alcohol. He was in prison for a long time. We were able to get him out because he was going to be injected with naltrexone, the Vivitrol. And we had him out, but he also had to wear an alcohol monitoring bracelet. And David and I both got the call about the same time in the middle of the night. He had been involved in an Amish buggy accident, and he panicked and ran. He left his car. They found him 2 days later. Now, what chance do you think we would have of winning a trial on whether or not he was under the influence of alcohol? Or even if they couldn't charge him with alcohol, they would charge him with something more serious. I'm not going to get into that right now. But we were able to go to court and show the court over 4,000 tests that proved that he was not under the influence of alcohol for not only that day,
while he was driving,
for
he was
several weeks. Do you remember that case?
I do indeed. And that
he's probably one of the few people in America who could prove that he wasn't drinking. And thank goodness for that alcohol monitoring bracelet.
You raise a very good point, Angelo. I believe that one of the greatest benefits to consider if you're a clinician or a treatment specialist is that this provides proof, not in terms of the concentration of alcohol in a bottle, but I'm talking about proof that the individual is compliant over a period of time with certainty. There's no doubt about it, because the hallmark of alcohol, hardcore drinking and moving toward alcohol addiction is they're going to drink secretively. They're going to try to beat the system. This does not permit that for that period of time in which they wear it. Now, interestingly, we've seen some very extended long-term court sentencing to this device. Most recently, we had a country and western singer in central Pennsylvania who was in Texas. And he was doing a gig at a bar, and he was singing, drinking, and he packed up to go home at the time the bar closed. It was a foggy night, and as he's driving home, he thinks he hits a deer. He gets home, goes to bed, wakes up the next morning, and the news, someone was killed on a bicycle on the road that he travels. When they looked at the car, indeed, they found that there was signs that he had hit this individual. So he went to court, did some jail time, and when he came out, I found that Texas law and judges are very stern. They sentenced him to 10 years on this bracelet as a condition that he would be released from jail. So he is on this for 10 years because of a demonstrated repeated past of alcohol abuse. That's probably the most extreme case I've ever seen, but I just wanted to share that with you, that we see most people on this 90 days.
We also have something, and I'm hoping Dr. Capretta can maybe at least correct me on this, but there's a term called alcohol deprivation syndrome. Now again, I am a person who is about to enter Easter, and we've all been going through Lent, and in my religion you give something up. And as a kid I can remember giving up chocolate, and on Easter Sunday eating a 500-pound chocolate egg.
Been there.
So there is alcohol deprivation syndrome, from what I'm told by doctors, is a real condition. And this goes to show you how that coordination now, alcohol monitoring is accepted by many, many counties now in many, many states. However, the alcohol monitoring people might do well, it's my pitch here, to work with counselors and doctors, because it's significantly likely that when that bracelet comes off, they may have a drinking episode that could be a grand one.
Certainly.
And that might be I'm not a doctor, but if I were a doctor, I would like to think that I might have some tools in there, like a naltrexone-based something, to prevent them from, because the Vivitrol, for example, was developed first, as I understand it, for alcohol. It was approved for alcohol first before it was approved for opiates by the FDA and whatnot. So again, one more connection of all these people working together.
Yeah. Lastly, I'd like to dovetail into what Bill was referring to, the pretrial use of counseling treatment for individuals who are about to go into the court system. There is a publication out of York County called the Target 25 program. I don't know if you've heard about it, Bill, but Judge Kennedy at York County discovered that they had such an enormous problem of repeating DUI offenders. Once a person is arrested and then sent to put into the process of going to trial, there could be anywhere from a 3 to 8 month period, maybe longer, till they could get to trial. What they found that in York County they had 225 repeat DUIs in that interim period, during that hiatus from the time the person was arrested to the time the person goes to trial. 225 cases, 25 accidents, alcohol related among that same population. They got together the police, the warden, probation department, what would be a CJAB equivalent here, counselors, and formed a team, and they looked at the problem. What do we do about this? This is clogging the courts. We're seeing a public safety issue. What can we do? There was great pushback from the police. This is an unfunded mandate. We can't do this, but they decided to launch a program after 1 year utilizing rapid intervention by the police and the magistrates and treatment. They would bring individuals in who had demonstrated second-time DUIs or high BAC arrests. They would immediately go into a monitoring program in lieu of bail on this device.
There'd be a
continuous
bond
alcohol
issue.
bond issue. Thank you. And they, after 1 year, looked at the data. What do you think happened? 225 in 2011. In 2012, they had 5 repeat DUIs. They had 27 alcohol-related accidents in that same population in 2011. They had 2 or 3 in 2012. The efficacy of this in the hands of Judge Kennedy is just remarkable. These programs have really taken off in eastern Pennsylvania. We do not have any here in Pennsylvania, with exception at Butler County, where the magistrates now are looking and evaluating each case and saying, well, what do we do for that individual? My problem is, we see 25% higher positivity rates in that pretrial population. We're assessing, essentially, and saying there are individuals here that we know are problem drinkers, but we now can look at those who are out of control. The uncoupling, and the challenge to Bill and Neil and to treatment professionals is, what can be done for that individual in the pretrial mode? Sure, we don't want them driving. We want to identify them, but what happens? There isn't anything that can happen right now.
And again, the connection, and I can answer that question partially, the connection is having the lawyer specify early intervention. Generally speaking, a lawyer rarely shows up at what's called preliminary arraignment. Arraignment is when you're told what you do. Generally, an attorney won't show up at that. We always show up at the preliminary arraignment because the bracelet and treatment would be part of a condition of the bond, or we don't take that case. Early intervention is as much responsible for that success as that device is. And the earlier the intervention, the better. And by the way, that system, you're right. A person who is charged with a crime, if you throw in and Bruce Gellick, my paralegal, can tell you this, if you throw in the continuances and whatnot, by the time you feel in jeopardy on that case, it's at least 8 months. At least 8 months. And actually, the pressure of that hanging over their head, we've seen people even drink even more. Okay, we're ready to move on now to Dr. Iacino. And Dr. Capretta, you could retake your chair there, and we're coming down the home stretch here. Dr. Gilreath, would you please recite your name into our record here and your qualifications and your experience that brings you here from Erie?
Valerie S. Gilreath, DO, board certified in neurological surgery, retired, board certified in family practice, and I've been doing opioid addiction with Suboxone for the last 3 years. I also do prison medicine for the last 6 years at Albion Prison in Albion, Pennsylvania. Presently, I'm retiring from Pennsylvania and going to Arizona, where I'll be practicing prison medicine and addiction medicine there. Training, I think, is kind of important insofar as it'll give a reflection of why I've dedicated part of my life to this. After graduating from Green Cross General Hospital, which was in lovely Cuyahoga Falls, Ohio, I went to Detroit, Michigan for my training in general surgery, which was 2 years, and neurological surgery, which was 4. And in the 1980s, it was the murder capital of the world. They, at that particular point in time, had more murders than in New York City. In fact, Dr. Spitz, was the coroner. He was able to harvest so many pituitary glands for growth hormone, they accused him of actually selling that for those that had dwarfism. Seeing gunshot wounds to the head was a regular Friday, Saturday night. Knifings. In fact, I saw my first knife wound to the skull in Detroit and was able to handle such ramifications of my specialty at that time. Motor vehicle accidents, you could come in Friday and probably leave on Sunday for the number of automobile accidents requiring multiple surgical assaults in order to save them. And of course, the rehabilitation. Of course, I think we had one of the largest rehabilitation centers, I think at that particular point in time in the United States. When Operation Desert Storm occurred in the 90s, they took everybody from Detroit Receiving Hospital, and that became actually the reserves that they needed to take care of our own wounded. In fact, lucky for us, it was mostly the other guy that got wounded, and they were treating them as opposed to many of our own soldiers. The real impetus to get involved with it, my partner, Leo Swantek, son, he had twins, died of an overdose of heroin and Valium, which was administered by his girlfriend. And that just wreaked his life and his wife to such a point that two very nice people, and he graduated number 2 from the University of Pittsburgh in his class, just destroyed him. And my goal of really getting involved is how many people can I save? How many deaths can I prevent? What can I do to stabilize these people? Going for the complete cure, I think, is idealistic. I think that's the goal, but I think the primary purpose of what we try to do is save lives and really educate other people that this is not something you really want to get into. You really want to understand what drug addiction is about. And I'm just amazed that this country legalized marijuana in Colorado. In fact, in less than 3 months, they've almost paid off their state debt. And now another state is considering it. And at this particular point in time, whether you consider marijuana the gateway, we know it's recreational. Treating people that have opioid addiction and use marijuana in my program, they can't be on it. And if I get them off it, they notice quite a difference, not only controlling their addiction through Suboxone, but by getting them off the, if you will, the THC and getting them off of the benzos, they have an entirely different outlook on life. So I think Suboxone's a gateway, but the problem has been far from addressed in this country. In fact, it's getting worse.
And Doctor, you have worked with us for several months now. In fact, it's over a year. You were a part of our instructional staff last year, and we thank you. And you're going to be part of our staff this year. And we are hoping that we're going to get something like what we're doing here started in Arizona. We're planning on following you out there, and we've actually done some groundwork out there. But Doctor, your experience mostly is in that Suboxone area, and you had missed one of our other speakers, but we talked about transitionalizing from Suboxone into and using all the rest of the tools. But we're most interested in moving past that subject in what you offer in this prison issue. Is it your experience that most prisons, including the one you work in, do not allow any form of pharmacotherapy or any kind of medical assistance to their treatment programs?
Yes and no.
Okay.
That's how the system works.
Mm-hmm.
If somebody goes in there that is dependent upon an opioid, they're put in a POC, which is nothing more than a psychiatric observation cell, and basically told to sweat it out. They're only given, if you will, Clinarol, Catapres, 0.1 or to 0.3. They're giving something for the diarrhea and something for the nausea, and they stay in there until they're detoxed.
But as far
and
as
no other treatment except when they get a chance to see the psychiatrist.
Okay, and generally speaking, if Dr. Capretta had a patient that was in that prison, he would not be able to administer the naltrexone, would he?
I have my own patients in the hospital, and in fact, they're on a patient list to come in and get out. Naltrexone, no, we don't use that.
And when you say we don't use that, you're not permitted to.
That is correct, and I doubt if it ever would get into the prison at this particular point in time.
Okay, so, and that's one of the arguments that I, as an attorney, make to the court system, and I just made that argument and in front of the Virginia Supreme Court on Tuesday, that taking my client out of home confinement and putting her in the state penitentiary was separating her from treatment, which I don't want to get into, but I have all kind of Eighth Amendment issues on that. And so the fact that I was in front of the Supreme Court already lets you know how many times I have failed to make that argument successful below. And I don't know what chances we have there either. But generally speaking, the state penitentiary system does not allow any type of medication, even if it's prescribed, for their
At this
patients.
particular point in time, what's gone through the state system, that they no longer allow any narcotics to be administered to any inmate without previous approval from the, what would be, how can I say this, the administrator, which is Wexford. He has to okay it because of the use of Tylenol number 3, Vicodins, methadone for pain control, which also we know can use for detox. It's gotten to such a point that patients were becoming apneic at night because of the narcotics, and if they get the other combinations, they get the psych drugs, which is another problem. So you add that with along with the opioids. I mean, you have got a concoction going there, and things are out of control. So finally the state has said, no more, period.
And your answer is very revealing, because they believe that any kind of medication is a narcotic. They're behind on not knowing that this is not an addiction medication. So Dr. Gilreath is one of our people that we're trying to take this into the prison system and take them into the treatment mode and whatnot. Anyway, did you have anything else that you wanted me to add before I move on to Dr. Iacino?
The only thing that's kind of important in prison medicine that people have to be aware of is that you hear about these treatment programs, okay? They're really not really treatment programs. You have to remember that a psychiatrist no longer runs the psychiatric section. It's the psychologists that run it. And of course, they're now dictating to the psychiatrist what medication should be utilized, although they didn't have the permission, the ability to write for it. So with this change, I'm very fortunate to have an excellent psychiatrist, and I'm not afraid to talk to him, and he's not afraid to talk to me, that a lot of the medications these people are on is not justified. They can actually describe the symptoms of the psychiatrist, but not actually have it. And that's what the psychiatrists and the psychologists don't realize that are in prison medicine. You have to separate those two. And from that, you give the appropriate medication, the appropriate treatment, whatever it is. You can't be dictated by a psychologist. It has to be done by a psychiatrist that is aware of when they're being shucked and jived, as we say.
And Doctor, just to grab onto that for a second, I know in working with Bill and Nessa that they almost always try to get a referral to somebody, to a psychiatrist, at least an intake. And Doctor, we believe it may be much more complicated than just an addiction and whatnot. So am I wrong in saying that at least a referral for an intake of observation or assessment from a psychiatrist would not be a bad thing?
Well, either that or from a social worker that can really take a good history. And that's very important. Without that social history, in fact, our psychiatrist, Max Gausman, says, I need a social history. And he's having a hell of a time convincing these psychologists out there that it is under his responsibility. You got to get a social history. And they're complaining about it. Well, without it, you're dead in the water. You can't treat the problem or make an attempt to do that.
Great. Okay, thank you. We're going to move to our last speaker now. Okay. Dr. Iacino, thank you for coming and patiently waiting. And this really is a situation where we have saved the best for last, and I mean that in regard to nobody's the best here. But if we had to pick one, it is my firm belief that this addition to what we have become is a vital addition. We know that lots of talk shows are out there, and we talk about talk shows once in a while when you and I are just socializing. And we know that you might choose one network because your political leaning is more expressed on that network, and you might pick another network because of your political leaning. But I have to say that although I definitely have political attitudes, and I'm not going to share them here, I definitely am not happy with either side in this bantering and this rancor and these what I call soundbite intellects. The human body, you guys are medical men, needs to be properly nourished, and we know that if we stopped every day at the local gas station and pulled a lever or bought cheese crackers 3 times a day, we would probably survive and we could drink water. But is that a nourishing meal? And to me, sound bites, websites, fragments off of these talk shows are like junk food for the intellect. I mean, they're quick, You can take the edge off. You're no longer hungry. Okay, but do you really know the subject? Okay, and we know that we have our drug summit coming up in Kennedy Catholic High School, and our drug summit has a lot of exciting things going on. By accident, we found that we have stimulated the kids, and that's very important to us. So as a result, it kind of shoved our intellectual side, around a little bit, and that's why we have this special session here for this deeper discussion on the contemporary issues. And we hopefully we can keep this panel together even when Doctor is in Arizona on go-to-meeting or things like that, where we can form this advisory board similar to the group that you had me talk to Dr. Capretta recently. And it's a great idea, the like-minded professionals group. So that's very important to us. And we want to be able to talk in depth for something. We don't want to be just talking in sound bites and me rattling off a bunch of statistics that sound okay. We want to have a learned opinion on this thing. Nobody has the answers. This is a very difficult problem, but unfortunately, nobody is talking in depth on the issue. So we want to also, that not only are we reaching the children, we are also educationally reaching forward to the highest level of understanding that there is possible, and always be open. Come, let us reason together, and let us reason in an informed way. So finding a school that would welcome us like Dr. Iacino did was very important to us, because we are professionals, and we are professionals in what we do, but are we professionals on how to get along with each other? How are we professionals on how to work together? Why not be taught by professional educators some of those personal skills and whatnot that are lifelong? And by the same token, isn't it a great idea while we're there to proactively reach as many of these kids as we can and reactively meet as many on the back end? So Dr. Iacino was very, very courteous and saw it immediately. We talked, and he recognized it, I think, as another way to teach these children. So without going any further, I'm going to say again, we have definitely, because this message that we have here, there is nobody who could leave here today that know that we didn't talk about some very important things, and we discovered a lot of good ground here. Isn't it a shame that nobody but these people sitting here will hear it? But now this is our opportunity to put it out there. And not only put it out there, keep it out there. And every year it comes back and it just gets bigger until we have a ongoing learned discussion about one of America's biggest problems. So Dr. Iacino, I will do the same thing I asked everybody else to do. First of all, I'll ask you to identify yourself and your credentials, and then we'll get you started.
My name is Peter Iacino. I've been an educator for 40 years, 35 of those as a school administrator, 27 as president of Kennedy Catholic High School, and then currently vice president of the Shenango Valley Catholic School System.
And you also had a stay in coaching, correct?
Oh, I've done just about everything. I've been a coach, an AD, a teacher, obviously administrator, and many, many other things. Swept the floor once or twice, too.
And I heard you were a hell of a point guard once upon a time.
I played a little bit, yes.
So why am I saying that? It's important for us to bring all of our talents and our experiences to life here. You're listening to an old football player, a high school teacher, assistant principal in a high school, failed running for state house of representative. People still accuse me of keeping an inflatable podium in the trunk of my car because I'll make a speech any second. An attorney, a prosecutor. All of those things come back to this idea that, darn it, we're a member of this community. We're a proud member of several professionals, and we've got something to say. And we need people to hear it. But we can't get anyone to listen to us. Thankfully, you have allowed us to come to your school, and I think that's a groundbreaking thing. So
well, it's interesting that you mentioned that particular aspect of delivery of information. And there's no perfect way of delivering information. So traditionally, and we'll talk about these very, very important issues, and very important issues to parents, to families, to high school students, to middle school students, and so on. You know, every school does their usual stuff in talking about drug and alcohol problems, abuse problems, addiction problems, and of course, you know, the message along with that is obviously we don't want you to do it. And that takes a variety of ways that teachers and others do that, from the lecture method to reading assignments, to bring in guest speakers, to multimedia presentations, to technologically deliverables. And when we started talking about how can we add another voice to the message that might be a little more real than some of the things that go on in a traditional classroom? And from that conversation and the confluence of medical professionals, law enforcement professionals, legal professionals, the judiciary, and educators, how can we come up with something that may be more real to students and at the same time engage them to the message that we all want them to hear? That these are the kinds of things that can happen if you involve yourselves in alcohol and drugs. This is what can happen even if you don't personally involve yourself in those two things, but are associated with people who are. And there's a danger involved in that. So what we came up with, which was very effective last year, and we're continuing with this year, is this real kind of life, real dramatization of being arrested, going to a preliminary hearing, and going to trial. We use students from our school as the subjects of the exercise who were arrested for an alleged offense. We take them to a preliminary trial, and they're represented by real-life attorneys, and there's a real-life district justice there for the preliminary hearing. We go through that process, and then a number of months later, which will be in a couple weeks now, we'll follow that up with a real trial using a real common pleas court judge, real attorneys, real policemen, and go through that whole procedure and using also kids from our school as the jurors. And so we do that. We did that first time last year. This is the second time we're doing that. And that becomes, I think, a lot more real to the students that we're addressing. They see their own peers, and if there are some things going on in the school, they know who they are anyway. And what could happen to both someone who is involved in alcohol or drugs, particularly at the more criminal level of distribution of controlled substances, and also what can happen to a student who just accidentally or non-accidentally is around that other student when that student is arrested, and what that implication to that student may be. And so that'll all play out by trial for those two students in a couple of weeks, and we'll see how the jury decides those cases. But it is a real-life demonstration of what can happen on the very, very, very negative side of being involved in alcohol and drugs. And that's just one aspect of what we started to do. And then with the other professionals that we've been talking about, and some who are here who have participated, we take that message even further to the community at large. So we want to engage parents. We want to engage other professionals in this discussion about what's going on, how we can attack it, and I think you're probably right. We hope, I think the best hope is we're at the end of the beginning, and obviously not near the end, unfortunately, and just engage more and more people. The more people you make aware of what's going on, what's happening, what the treatment options are if it goes to abuse and addiction, and so on and so on, and the more you do that, the better I think we'll make everybody in the end.
And it has many moving parts to it. The first thing I want to do is pick up where you left off on the real life. I've been an attorney for over 25 years, 7 of those as a prosecutor. There is not one bit of artificiality to the charges. The policeman actually filled out a real affidavit of probable cause. They pulled the person over. The student is seen doing the field sobriety test on camera. They watched the movie. The other child got out of car totally by accident. He's in that car, and underneath his seat is a whole bag of stuff. And it turns out that the weight of the stuff is so heavy that the magistrate at the preliminary hearing, which was done by the book in your school in November, they actually denied him bond, cuffed him, and walked him out of the preliminary hearing. You could have heard a pin drop in that gymnasium. So what we're trying to do is make that real, and then the trial is real too. In fact, the losing attorney has to, you don't know this, but the losing attorney has to give your school $200 as a donation. I wanted to pick it up a little bit, ratchet it up.
I think
a
you
little
should
bit.
really put pressure on them and make it 1,000.
Well, the other thing was too that after last year's thing, it was such a real life thing. There was an acquittal, and I do have to say that hopefully the attorneys won't know this for their due process rights to be violated. But Dr. Asina said he wants a conviction this year, so we will have the trial by jury. But again, it is 100% by the book. The documents are exactly the legal. David, you've seen hundreds of these, the affidavit of probable cause sheet, how the arrest was made, everything. The policeman did it by the book. The bond was denied. There'll be a jury trial. And not only that, because the preliminary hearing happened in November, they have several months to be looking forward to the actual trial that's coming. Okay, now, very important, the fact pattern too. This person seated in that car that had taken that ride by accident could very well be convicted of possession with intent to deliver, a felony offense. So the one message we're trying to send to the good kids too is that by accident, it's that easy to get a felony conviction. And then we also, doctor, show the Vivitrol video on the bonding of the antagonists and whatnot. If you've ever seen that on the Vivitrol, we show them how one exposure to an addicting substance can hopelessly addict you too. So the message is that you can't make even one mistake sometimes. That one message we want. So that's the kids. Then we also know that we've been in places like this trying to get to policymakers, the people who hold the checkbook in government. We want to develop the political will to do something about these problems. So we know they have an attention span that sometimes is not as long as ours today. So in the middle of the day, we have the opening ceremony, which is 1 hour only. And we will have a procession into the gym of all of our speakers, a very formal thing. There'll be a musical accompaniment. National anthem will be sung. Then we will have a moment of silence for any fallen first responders or students overdose and whatnot anywhere in the country. And then we'll have a little 1 hour luncheon. And at the end, in the afternoon, Dr. Capretta, you were there last year for one of our main speakers. We will have main speakers, and this year we will have Judge St. John. We will have Judge Durkin from Mahoning County Drug Court, they just celebrated their 13th anniversary, and there's a little film clip on that. And we're now attracting other judges from other counties and other states and other school districts. We have a convention-style atmosphere so that it gets bigger and bigger. It's not just for Hermitage. And then they're adjourned, and then the next day we have CLEs for lawyers, CMEs and whatnot for medical people, and Act 48 hours for teachers. So it's a 2-day event that reaches the entire community, hopefully, and that's the goal. And the goal is to have as many of these in as many different places, not just Kennedy Catholic, and have as many as we can. So that, and again, we're not on anyone's side professionally, we're not on anyone's philosophy professionally, we're just providing a forum for us to bring this to the forefront. Let us reason together in a learned fashion and do it in front of the kids if we can and make a difference. So, anything else, Dr.?
Yeah, I can't emphasize enough how impressive it is to community, staff, and students when you bring in high-powered people to do what we're talking about. It's one thing if you have a group of kids stage the entire thing and act as judge, jury, and all that, or attorney. It's quite another when you bring in a common police court judge. And even in our case this time, this particular judge is also a graduate of the school, which adds even more impact to what we're doing with students. But the issue always is the same. What can you do? What is it you say to a middle school student that has not done anything, that might be thinking about trying alcohol or drugs? Or what do you say, in addition to everything else we're saying already, to the high school student that maybe has tried it recreationally? Or what do you say to those that are predisposed to abuse or addiction when you don't know who they are particularly, but there's got to be some in that audience that are? And this is, again, one more powerful message to all those students, and a very, very important one. And those professionals that participate in this kind of thing is very gratifying to see. I think it's extremely important to our community, our students, and going forward, I hope to a lot of other communities.
Okay, gentlemen and ladies, thank you for coming and taking time out of your busy day. And I'm thanking you in advance for coming on April 25th or someday in the future, wherever we're at, in Arizona or Pennsylvania. In Ohio, we have a couple different places that want to put these school events on. And I thank you in advance for coming next year or to the next town that we go to, and also to becoming part of our advisory board. And again, thank you so much, and I'll let each one of you close if you have any words of wisdom for the people who will be watching this. And again, from the bottom of my heart, all sincerity, thank you, thank you, thank you.
Well, from my standpoint of view, as a physician, I'm glad to see the legal profession actually take a proactive role in addressing a serious issue that's really facing this country, and it's drug addiction. I also applaud Dr. Osceola, and if I mispronounce it, please forgive me, for at least making an attempt to get education involved in making aware of the problem that we're facing today. One of the things as a spokesperson for Beckett Rickhauser is that they kept pressing, well, why don't you give more lectures, more lectures? Well, I'm lecturing to doctors. That's not the way to go. What we want to really get into about being able to introduce what drug addiction is and how it can be treated, and the end results, death, really play a part and have an impact upon our social life. Yours is the beginning. You're part of a situation like I am. Education has to be revamped. My avocation is really the practice of medicine. My vocation is driving my Harley-Davidson motorcycle. Do you know what it's like to go around in the summertime and see empty baseball fields? Where are the people that we look towards that spent and volunteered all the time when I was growing up and when you're growing up, Little League baseball, Little League football, soccer, whatever you want to, they would do anything. Where is it gone? This has all been replaced by the computer, and it has compounded the problem of drug addiction, isolation. We're not getting enough commitment from our leaders. We're not getting enough commitment from our government, but it's a start. And I'm proud to be part of this program, to at least maybe we can get an initiation or set a fire into somebody to really spread the word that we got problems in this country. And it doesn't have to do with drug addiction. It has to do with our leaders. It has to do with what our original goals were. And we really have to go back to what our founding fathers really encompassed in putting together the Constitution of the United States to make this one of the greatest countries in the world. And that's all I have to say. And I'm looking forward to seeing you again at the meeting.
Just a couple final thoughts. When I was listening to David Sproat talking about all the current electronic devices that are available to monitor behavior with regards to substance abuse, it just kind of reminded me of a couple of people that have passed the word on to me through the counseling sessions, that the more obstacles that you can put in place to slow down someone's addiction, generally the better the outcome. And as Dave was talking about that, I kept thinking that it does seem like it's Big Brother to a certain extent, but I think it's something that could be used for good. And again, if you can make it more difficult for people to continue with their addiction, you buy them some time that may save their life, because it is, as the doctor said, a progressive terminal illness, and we see that all the time. Just one last note, it's been a pleasure to be part of this panel discussion. I wish there would have been continuing education units for it, because I really learned a lot just listening to other professionals talking about what they do and some of the latest developments. And sadly, even though it's 2014, we live at a time when there's still a lot of denial about addiction and a lot of apathy. Generally, if it's not occurring in your neighborhood, sometimes people just don't want to talk about it. But I think what we talked about here today was very important, and hopefully the events on the 25th will be a continuation of that. So I just wanted to pass that on.
Let's say that alcohol and drug problems do not discriminate. They affect people of all socio-economical groups. Common problems, depending on different numbers you look, over the course of a lifetime, anywhere between 10 to 20% of the population will themselves go through having a significant problem with alcohol or drugs at some point in their life. And for every person who has a problem, there are 4 or 5 other people significantly impacted by that person, family members, other neighbors, co-workers, and there's a whole series of even layers beyond that. So this is a very common problem, and I know the people listening to this, there's many people in the audience hearing this that themselves or somebody they care about is struggling with the problem. And the message I want to give is there is hope. Do not give up. Treatment does work, recovery does work, but you got to reach out for it and you got to stick with it. And the good news is you don't have to do it alone. There's good help and support available, and we need to use all the tools in our toolbox to get the best outcome, whether they be medicines, therapies, using the legal system as an opportunity to provide the care and not just get them off, to really get beyond a legal thing to a humanistic thing. And it's good for the person, it's good for all of our society. And I really want to congratulate this work group for this great conference you're putting on in the work, and hopefully it'll continue for many years. Thank you.
First, let me say it's an honor for me to be part of this panel today among these very, very distinguished professionals. But my sense is they're way beyond professional. Those of us that work with people, work with kids, work with adults, sort of see that as an avocation, and we're committed to doing all we can to help the plight of those people out there. In the area that we're talking about, which is drug and alcohol use, abuse, and addiction, we're all committed to saving every life we can, saving every individual we can, in any way that we can. These summits help in that regard, and certainly I offer a tremendous amount of appreciation to Angelo and to all the people here who participate or will participate in the summits that we have coming up. And once again, thank you for allowing me to be part of it.
Listening to all these gentlemen talk, obviously there are so many aspects and avenues to go with what to do with somebody once they already have a significant drug or alcohol addiction. But there's always that reminder that you need to look backwards sometimes to how a person got there. They have originally, you had those big divisions between the mental health and the drug and alcohol, and there was a huge debate for many, many years of which one do you treat first, which one's primary, how do you address it? And a lot of it comes down to you have to do it together. You have to do it together as a team, but you also have to do it together with the client. Find out what is behind the addiction. And most of the time there's trauma, there's negative things, there's bad things. And if you just strictly take them off of their substance of choice, you're taking away the only coping skill they have. And if you don't integrate a lot of the other components, you're setting them up to fail or worse, which is very scary and very sad. What I think is great about these summits is that they do include the kids, and they do give them that bigger perspective that as bad as things are now, where substance use might be an ideal fix to something bad going on, it can make the situation so much worse. And when you're young and when you're a teenager, you don't look that far ahead. You look at where it's at. So I want to thank all of the gentlemen who were giving such good information. I actually learned quite a lot just sitting back here behind the desk with them.
I would like to thank Angelo for coordinating this meeting today with the panel. It's certainly an honor to be participating with you, but I think I took 4 pages of notes as each of you were speaking, so indeed, we really do learn a great deal. I look forward to seeing and learning more, and especially seeing how your program will tangibilize what really happens to individuals who get caught up in the legal system because of drugs and alcohol. But some say, we all lead quiet lives of quiet desperation. I think none more than the person who's afflicted by drugs. So it's really also very gratifying to see the commitment and what you do and the dedication, looking at root causes and ways to help and differences that you can make in the lives of people. I think it all comes down to hope. I think we all hope that we can help in some way. So I applaud you for being here, and thank you for including me on the meeting. I look forward to the show on the second annual Kennedy meeting.
People who are leaders.
Who's the greater the effect? buprenorphine gives a strong opioid effect, but at a medium level, it
see a young man who a lot of and who has tried.
This is a new day. This is a new day. Show up and share. To the people that are back.
We are the lifeguards of tomorrow. We are creating the future by predicting the future.
That the only way you can predict the future is to make it happen.
This is the vision that each one of us can help save ourselves, our family, our friends, our clients, and our patients.
Is to deal with our fellow human beings on this earth with compassion and a recognition that there by the grace of God go I.